minutes. Yes.
Vamos a comenzar con la primera clase de proteínas terapéuticas.
So I can start. Okay. So buenos dias. I'm going to talk today about recombinant therapeutic proteins. So just to present here the general workflow of to produce a protein, recombinant therapeutic proteins. So here you can see summarized in this slide all the key steps allowing the production of the therapeutic proteins. So first, you can see oh no, sorry. Okay. And this one, just to try something. No, yes, I think so. Sorry. Ah oui, no, sorry. Oh, j'essaie de voir. No, it's not there. So I leave it. Sorry. So you have the case step allowing the therapeutic protein production. So here, the construction of the vector that will be transfected to the host cells. Then the host cells will be cultivated to be then and the cells obtained will be seeded in bioreactor to scale up the production of recombinant proteins. Then when you obtain so this first part is called the upstream process of the for production of therapeutic proteins. Then the second part is called the downstream, because once you harvest, you obtain the harvested cells produced, you collect the protein release. You need to purify them, to polish them in the purpose to eliminate apparented products such as dimers or whatever, and then the drug substance obtained will be formulated to obtain the drug product that will be commercialized. So first the upstream process for the scale up of the protein production, and then the downstream process where the protein produced here will be purified, polished, and formulated. And that's the downstream process. So to present these different steps, here you can see a schematic representation of the step the first step, which is dedicated to the development of the vector that will be transfected, for instance, or in the expression system. In this case, it's Escherichia coli. So the DNA or the gene encoding for the desired protein is inserted here in the recombinant molecule thanks to the ligation process performed by enzyme called ligase, and then the plasmid obtained is transfected here in the host. In this case, it's Escherichia coli, which is a host widely used in the production of therapeutic protein, and then the protein will be produced by this host. So here you can see a summary of all the sequence from the DNA to the therapeutic protein. So as I say, you have to choose the DNA sequence, and you can find, as it's publicly available on database, and especially in the National Center for Biotechnology Information in the USA, or in the European Molecular Biology Laboratory, in the case of Europe and USA. Then the sequence of the DNA determined will be amplified. Most of the time, you need to amplify the DNA to obtain a good insertion of the gene inside the plasmid. Then, depending of your purpose, you have to select an expression host. Escherichia coli is a bacteria, the yeast, or mammalian cells. Depending, because sometimes, I will explain that later, but sometimes protein needs to be glycosylated to be more stable. In this case, we'll choose mostly mammalian cells or sometimes yeast, because Escherichia coli is not able to glycolyze properly proteins. So depending of the protein, you will choose a different expression host. Then you transfected your vector in the host cell, and then the host cell will transcript the DNA into mRNA, and then the mRNA will be translated to protein, so as you know. And then once the protein is produced, he will submit what we call post-translational modification. It could be a disulfide bridge, glycosylation, or whatever, and that's helped the protein to be folded in a functional 3D structure. Otherwise, it could be sometimes, for instance, for an enzyme, if the 3D structure is not properly established, the enzyme will not function because the active sites will not be available. So different modifications are crucial, such as glycosylation in the mammalian cell. And then the protein, as I presented before, will be purified and formulated. So then when you obtain, here is an example of a plasmid for a mammalian cell line, designed for a mammalian cell line, sorry. So you can see here what we call ORE, which is origin of replication, which allow plasmid to replicate separately from the cell's chromosome. Then the last sequence called MCS that you see here, it's multiple cloning sites. It contains recognition sites for a large number of restriction enzyme, and is located near the promoter, that, as you see here, and it enables a flexible and easy, or more easier, integration of the DNA desired for the corresponding to the protein that will be produced. Then you have also antibiotic resistant genes, for instance, is neomycin resistance. And this is a selection marker that enables the selection of the mammalian cell who have integrated the plasmid in their chromosome or not in their chromosome, depending of the system. And it's important that because this antibiotic resistance corresponds to a segment of DNA who allow the cells to survive when the antibiotic is added in the media. For instance, here is a neomycin. And the mechanism of action is quite different. That could be an enzyme who degraded the drug, or it could be also an activation of a pump of efflux who expel the antibiotic from the cells. So I talked already about the promoters who drive gene expression. So it allows the binding of a factor who initiate or stimulate the transcription, because it's the DNA that will be transcribed in RNA. And then at the end, you have the polyadenylation recognition site. It's these sites who signal to the enzyme that, okay, it's the end of the genes, and now you have to polyadenylated the gene, and then that will lead to the production of a mRNA bearing this polyadenylation at the end. And this is important because this helps to stabilize the DNA and facilitate its transport through the nucleus to the cytoplasm. All right? And also it helps to promote the translation of the mRNA in the eukaryote cells. So here is the different type of tools who can help to transfect the plasmid. So here is a viral vector, as you have seen yesterday. Mostly it's adenovirus or lentivirus most of the time. So I have explained already yesterday that I think I don't need to develop here. The other method which is widely used is liposuction, but it has been explained yesterday by Hervé, so I think I don't need to come back to this explanation. And but it's also a method widely used for proteins. And the last one is the physical transfection method, such as electroporation, as I presented before, when you have an electric pulse who generate pore in the membrane of of the cell, allowing the DNA to the construct to enter the plasmid to enter in the cells. So just to present quickly the other system of expression. So here the bacteria. So the bacteria, is one of the most widely used system. Most widely used system, and because he is very popular because of its rapid growth. He's also well studied and well mastered by a lot of people. But his problem a little bit is that he is not able to perform glycosylation, and sometimes this could be detrimental for the protein because the protein produced by this way sometimes are less soluble and are more prone to form aggregates, as we can see here, and then you can. C'est pas moi. I've done nothing. J'ai rien fait. C'est Rafaela. It's not me. So what can be, leading to inclusion bodies, the problem that they can to avoid this. So to avoid this phenomenon of inclusion antibody, the experiment can be performed at a lower temperature, or sometimes manage to reduce the expression rates. Otherwise, another thing is to allow some protein to secrete more rapidly in the external media. So that's it. But it's a quite widely used, as I said, system. So here is summarized all the advantage and disadvantage of this expression system. The purpose is high protein yield, rapid growth, the cost of production are low, the gene expression is highly controllable, and many expression vectors are available. So that's why it's quite popular. Anyway, you have a lack of eukaryotic post-translational modification, the ability to form inclusion antibody, and also some bacterial enterotoxin that are produced in parallel. The other method is the other expression system is yeast, which is it's an eukaryote cell, it's an eukaryote microorganism, and it's a unicellular form with well characterized. The fermentation is inexpensive with a good yield as well, but able to perform post-translational modifications such as glycosylation, but it's a hypermannosylation, which is not the same sugar that used in mammalian cells. So after glycoengineering has to be done to humanize the products. You have a lot of protein anyway who are produced by this system: insulin, growth factor, some vaccine, and glucagon. The last one, who is quite used as well, is protein production in insect cells, and the virus used is the baculovirus, and which is a recombinant virus who bear the cDNA sequence coding for the desired protein and able to affect insect cell suspension. So you have several examples here presented here where this system of expression is used, such as, for instance, the vaccine against papillomavirus, or a product used to treat prostate cancer. So, and also another virus against influenza. Anyway, when you have, if I come back to the cell engineering strategies, we have to, you have to adapt and to engineer, to improve the productivity as well as the glycosylation. It's a two-way. You have many ways to do this. So first, to improve the productivity, what can be done, and to select the good cells, which is also an important thing. First, you have the adding of the gene coding for the DNA fragment, allowing the resistance to the antibiotics. But you can also use a selection marker, such as a glutamine synthetase, so they are introduced in the plasmid, and then this render the cell able to survive in a media free of glutamine. So it's a way to select the cells who have been transfected. Okay. Another thing is to also the same for the CHO cells. I mention this because it's a Chinese ovarian hamster cells, very popular, and they are mainly used for the production of therapeutic monoclonal antibodies. And here, in this case, the selective marker is the dihydrofolate reductase. Another thing is how you can manage. So here, to manage the selection of the transfected cells. Another thing is to improve the gene expression in the cells. So here, the purpose of this at this stage is to integrate the plasmid in a highly transcriptionally active chromatin region, what we call a hotspot, because it's not easy to otherwise, if you don't do that, the plasmid will enter in contact with the chromatin randomly, and he could select regions that are not available or regions who are available, which is the case when of the hotspot. So to choose the right region to be inserted in the genome of the cells. So the first generation tools is what we call Crelox, or the other one FLP-FRT. I just have a slide to explain what is Crelox. Sorry. So here, so you can see here it's a sort of book. You have here the what we call the LOX sequence here, and that's allow the Cre recombinase to link in this place. And you can see here the two parts of interest because it's located in these two inverted repeat terminal region. And you can see here the log 75 and the log 66. And for instance, this enzyme is able to switch between the two, to crossover between the two regions. And you can see here new regions called LOXP here, and which is based, which allow the assembly of this part and this part. So that's the first way to cross over and to help the system to localize precisely the hotspot. Otherwise, you have this region with a plasmid integrating a CRE binding domain, and he could bind precisely this region, the LOX 66, in the chromosomal site, and then thanks to this crossover, he will integrate selectively this region, and this region is known to be a hotspot. Okay. The other way is the second generation. If I come back here, is you have several ones: zinc finger nuclease, the TALEN, or the CRISPR-Cas9. I'll explain I will just explain one of them, which is the CRISPR-Cas9 here. So here, CRISPR for clustered regularly interspaced short palindromic repeats. And he's associated, as you know, with Cas9 protein, which an enzyme that has molecular scissors to cut the DNA. And then is associated with a guide RNA, which is a synthetic RNA sequence designed to match and to recognize the target RNA. And he's associated with a protospacer adjacent motif, which is a short DNA sequence following the target DNA, allowing the binding by Cas9. And then the Cas9 will cut here the genome. That two things could happen. It could be just glue by a non-homologous, and form what we call a non-homologous end joining. Otherwise, the other system is the use of a synthetic donor template, which enables the introduction of a desired sequence in the genome, which has been repaired. Otherwise, you have also another way to improve the gene expression, which is the use of here, allowing the here we act to remodel the chromatin environment to maintain in this place an active transcriptional test around the transgene. So here we have what they call first scaffold matrix attachment, who have an impact on the folding of the chromatin, stabilize the chromatin in a desired way, allowing a proper integration of the plasmid and the proper transcription. Okay. There is also what they call ubiquitously acting chromatin opening element. This element helps the chromatin to be in what we call a sort of relaxed form. It's a chromatin, if I remember. And in this relaxed form, the DNA is more accessible, and then the plasmid is more likely easy for him to integrate in the genome and generate and produce mRNA. And you have another one which is stabilizing as well chromatin, an anti-repressor element, but it's not reported for industrial production. But I just see it because it exists. But all this technology has a really a nice success. In fact, to increase the generation of a stable line expression, and are really popular in this field. So I skip. So another method to promote the cell growth and proliferation survival, a lot of genes can be added, can be overexpressed, and a lot of genes allowing leading to an anti-apoptosis effect, so that maintains allowing an increase of the living time for the cells. Also, systems that allow a down-regulation of pro-apoptotic gene that will allow as well the survival time of the cell. You have also the possibility to increase the level of protein involved in the allowing a better protein folding and secretion, and as well, at least, the glycoengineering. And the main thing is the main purpose in this case is to reducing the fucosylation, because the fucosylation is able to trigger something called antibody-dependent cell-mediated cytotoxicity, which leads to cytotoxic effects, which is not desired. And another thing is to increase the serialization, because it's increased the lifetime, for instance, of the recombinant protein, or mainly the recombinant protein in the live circulation. So because otherwise, if they are not serialated, sometimes you have in the liver cells who are able to recognize all the uncellulated protein, so you decrease the lifetime of the protein. So to increase and to allow this protein not to be recognized by these liver cells, you increase the serialization. Okay. So in this figure, you have a summary of all the way to improve the productivity. So the selection system, as I present you, so you have the antibiotics, the GS system, the way to target to improve the gene expression, so to target the site integration, to act on the chromatin, on the chromatin and help to stabilize the chromatin in the desired conformation. So because usually the chromatin, I don't think I have explained that, but I think you know the chromatin is made of histone and DNA, and the DNA stack around the histone to be protected. But when you need to perform a transcription or anyway a replication, you need the DNA to be detached to the chromatin. So some of this system act to relax in a way the chromatin and to allow a better proper transcription. You have all the way also to improve the cell growth and its proliferation. Also to something also to at the end to help the protein to exhibit a better folding and to improve its secretion, and you have all the eco-engineering part as I presented before. Then the purpose is to reduce the fucosylation and to increase the serialization process. I skip because I think I've already presented. So here is to present all the system used to produce glycoproteins. Personally, I'm really interested by glycoproteins because my field is therapeutic monoclonal antibody who are highly glycosylated, so that's why it's more easier for me to present this part. But you have here these different mammalian cells that could be used. The hamster one, for instance, for the hamster one, so the Chinese hamster ovarian cell. Otherwise, it's a baby hamster cells provided by baby hamster kidneys. From the human, you have, I think I already presented the human embryonic kidney cells. And you have all this one, I don't remember the name, sorry. And you have also these cells produced by mouse, the NSO or the SP20. And for instance, for the therapeutic monoclonal antibody, the most used system is the system, I think half of the therapeutic antibody are produced through the CHO system, and the other part is produced via this NSO or SP20 system, for instance, just to give an idea. So as I told you, you also can produce proteins through non-mammalian cells. I don't know why there is not the bacteria. You have the mammalian cells, so you have the bacteria, yeast, insect cell, and plant cell. And bacteria, as I told you, is widely used. And you have also transgenic animals who has been used as well. For instance, the first protein was recombinant therapeutic monoclonal recombinant protein was produced through from rabbit. So here in this table are summarized all the advantages and disadvantages of the different systems to produce recombinant proteins. So this is not glycosylated ones, it's protein in general. Just to compare, so you have the bacteria. So as I said, you have numerous cloning tools, and they allow a high expression level, which is practical if you want to produce a big amount of protein, and they are really easy to cultivate. Disadvantages, which is low secretion level. They are low secretion level. They produce a lot, but it's more difficult to secrete it, and especially sometimes because of the inclusion body problem. And also, they did not induce any post-translational modification, which is sometimes could be detrimental for the protein because it's helped a lot on their 3D conformation. The yeast, so you have numerous commercial cloning tools, as well a high expression level, easy to cultivate, but post-translational modification are not so. There is post-translational modification. They are able to, but it's not exactly the same of the mammalian cells, for instance. But also, for large protein, the secretion potential is low. You have also the filament tooth fungi, who have good, exhibit good secretion potential, but it's not so widely used and also generate post-translational modification. But you have a limited availability of cloning tools. They are more complex to cultivate, so that's another thing. And the mammalian cell, which allow, what is important is they allow production of complex recombinant large protein. For instance, the therapeutic monoclonal antibody is 150,000 kilodalton, so it's quite huge. It's also they allow post-translational modification. However, as well, the secretion level is low. They are sensitive to contamination. The media is complex, and it's also a high cost. But now the cost is start to decrease with all the production of the biosimilar, but still. So here is another way. So I'm going to skip. It's just a way to quickly compare the different. Here to compare mainly, in fact, the post-translational modification. So cleavage, glycosylation, secretion, folding, phosphorylation, acetylation. So I said it's still in French, but I think you understand. If it's oui or no, I suppose it's si or no. I think you understand. It's okay for you. But sorry, I forgot to translate. So you can see here all the what could be obtained in this case. For the cell, if we come back to the cell line, well, here you will find in this table the most common used cell lines. So as I told you, the CHO, Vero things, BHK, and so I have listed already. And here you have all the protein produced on this column. No, I forgot to say that indeed hybridon bar is also used for murine monoclonal antibody production, but murine 1. And the problem is now that we want to the monoclonal antibody produced through this line are mainly mouse and that could generate undesired immune response. So that's why it's better to use CHO or NSO, for instance. That's an example of several proteins that have been produced through this technology. So you have all the one here, the protein, here the expression system used to produce them, and the therapeutic domain. So if you are, I can give you the slide anyway after the lecture if you are interested. So, and here's just to it's other proteins that have synthesized, but just to explain why it's complex to produce protein, because it's huge biomacromolecules. Here 150 kilodalton. Here it's 30 kilodalton. They have also a high level of glycosylation. And you see, in here you have the three-dimensional conformation, and which is important to preserve, as if you want to preserve their biological activity. So I skip here. So what can we? So then, what happened once we have identified the system of production, and we know that we are going to, I don't know, for instance, let's say, present, we have chosen the expression system, the cell line, and we are going to, we have designed the plasmid, so everything has been done. That's the part of the research, okay. And in this case, because it's the early phase of development, the amount produced is very low, it's micrograms. Then after, when the development started, the scale is growing, and then milligrams will be produced. And after that, when we start the preclinical stage and the clinical trial here, the 3 phases of the clinical trial, we have to increase the level of production of the proteins. And you see at the end, this is dozen kilogram. And at the end, once at the end of the clinical trial, the biomolecule is approved, then the next step is the commercialization. And in this case, it's 100 kilogram of protein that have to be produced. So you increase again. That's why you have this famous what we call the scale up. So how it's so in the first the process start, as I said, when you have done everything, then you choose. You know that okay, I'm going to produce this molecule. So you have of course you have a cell bank storage, and you have to. You will have your you have your selected vial. You sow it and you expand the culture through a series of inoculant steps here. So this is the inoculate suspension. Then once this step is done, the cells are then further expanded here in bioreactor. They are seeded in a series of bioreactors before transferring the production, the final production bioreactor. So you can see here, and it's a huge tank. I think I have another photo here. Somewhere I put it, no? Right, c'est là. Sorry. Here, so you can see the different bioreactor, very huge one. So then when you have to purify, after the production of the protein, the purification step is also very impressive because in lab we are used, for instance, to the chromatographic column, 30 centimeter and of long and I don't know, 5 millimeter diameter. Then here the chromatographic column are very important. It's not really the same scale. So just for the I need photo. And so then, after that, there is a series of filtration steps. But it's really important, this step of production, because it's also what, it's explained also why when you produce proteins, you have a lot of variant. You never have, it's not, for instance, an aspirin, a small molecule, and then you can produce, based on this molecule, you can produce a generic. It's not the case here. You never have, it's not possible to obtain a generic for recombinant proteins, because you can have several variants, glycosylation variants. That means, for instance, one of them will bear 3 sialic acid, some of them 2, etc. You have also the system of alternative splicing. You have also variant, charge variant, because during the process you can lose 1 amino acids or whatever, which happen quite some time. So you have a lot of variants, and this is also due to the fact that it's very difficult to perform when you are here in the cell culture stage, in the bioreactor. Even if you feed regularly, I will present, if you agitate regularly, you maintain a temperature, oxygenation, whatever, all the mechanism the processing is never completely identical from the bottom to the top of the bioreactor. So that's why as well, this is why also it's very difficult to obtain an identical molecule. You have, but it's not the case. So when you obtain, when you have a reconstituted recombinant proteins, inside the protein is almost, I say, a suspension of biosimilars in a way. So here is you can see here the two type of bioreactors, but here is another one, because a batch bioreactor, you have different type of batch bioreactor. So you can have a batch reactor with all the cells, all the cells and the nutrients at the beginning of the process, and not during the whole process. The second possibility is what we call a batch feed, where all the cultures and nutrients are added intermittently or continuously during the whole process of production. Here, all the nutrients and cells are added at the beginning of the process. Here is at the end. It's continuously during all process. So here you see they are fed regularly, in fact. And at the end, you have what they call a continuous cell retention bioreactor, where here the medium is continuously fed and simultaneously removed through a separation cell division to return to the cell into the reactor. So it's continuously. So you have continuous feeding, continuous cell removing, and continuous everything. So that's also another way to produce the proteins. So what is important here to consider that in the first batch, what the drawback is that the medium composition is variable because you add at the beginning the cell and the nutrients. So of course the metabolites will be rejected in the media, and so that it could accumulate it. Here the increase of cell density is easy, but you have also automation and bioproduct accumulation that could also impact the production throughout the process. And here, which is interesting, is we have a continuous metabolite elimination. The medium composition is stable, and the degradation risk is reduced. So as I presented here at the beginning, you can see here the different type of bioreactor found in the different company. And so here is the result of what I present, in terms of cell viability, you can see here, and what happened when the comparison with the batch. Here the simple batch with the feed batch. Here you have the feed batch here, and the batch. The feed batch here and here. The two bioreactor, and here is the feed batch, but with a shaker, and so you can compare here the viability of the cell between the different systems, and we can see that here it's the conclusion is that the cell line development need to be rigorous, highly documented, and finely characterized to obtain the best production at the end. Because what's the problem here is we have once all the production has been settled, they still face different problems. First, what we call the host impurities. That means what we call the cell debris, nucleic acid or lipids who has been released, as well as the host cell protein who can stick to the desired protein itself. And it's really a problem because we know that even now, when a recombinant protein is produced or protein like this, they are never completely rid of the host cell protein problems. They are still there. They are highly decreased. The level is really decreased. The concentration is decreased, but it's still there. You have also sometimes microorganisms who are still there, viral particles, bacteria, as well as pyrogenic substance. You have also what we call process-related impurities. So, for instance, once you have product and you have purified the recombinant protein, you still have impurity which are related to the different equipment used to purify the protein. So I will, and you have also all the product-related impurity, because the proteins sometimes, depending on their structure and their properties and their physicochemical property, they can be prone to aggregate. That's the case of many anti-therapeutic monoclonal antibody. They can be also truncated. They can be also unfolded. So we have to, and that could be, and it's important because we know that aggregated protein and even small aggregate can generate immunogenicity So that means that when you have this immunogenicity problem, that means that you can lead to the production of drug antibody that could decrease the therapeutic efficiency of the product. You have also that generate unwanted immune response that could be detrimental for the patient health. So you have many problems anyway. So you have really to pay attention to that. So just to add few words about host cell proteins. So they are proteins secreted by proliferating cells and released from the dead cells. So sometimes when you in the CHO cells, they can secrete protein involved in apoptosis, for instance, or generate proteolysis, unwanted proteolysis phenomenon. We can also have extra processing of glycosylation. They also can generate inflammation in immunogenicity, depending on the protein. So you have also a lot of HSP with, as I said here, proteolysis, which is the same, with protease functions such as catepsin or serine protease or whatever. And you have also and this could lead, unfortunately, to the degradation or the fragmentation of the product of the recombinant protein produced. Sorry. So here is a list of therapeutic products that suffer to and we know that in this case we have they have HSP that they have not been completely rid of their HCPs, host cell proteins, and here you have the therapeutic product, the host cell, the effect observed. So, for instance, here you have they have observed cytokine release and upregulation of cell surface marker, so which could be important, or sometimes antibody formation, drug antibody formation, which reduce the therapeutic activity of the recombinant protein. So we have increase of cytokine release that could generate inflammation, that could stimulate inflammation process. So really, it could be a problem. So here's so I can skip. So that's why I come back to. So that's why, to avoid this as much as possible, even if it's not completely possible, we have to, once the protein is purified, is produced, we have to purify it. So here we are entering in the downstream process. Until now, from the plasmid until the bioreactor presentation, we were in the upstream process. Now we start the downstream process to obtain the drug substance and then the drug products. And so the first part one of the key part of the downstream process is the MAB purification. So first so the protein purification, and sorry, but I have forgot to say that I choose as an example what we call MABs, therapeutic monoclonal antibodies. Okay, is it okay for you? It's just just to tell. So here, first, that is a process. That is the different step to purify as much as possible the therapeutic MAB produced in bioreactor. So first, what we call affinity chromatography protein A. So here you know that the protein A recognizes specifically the IgG. Okay, but you know that, I think you know that probably. So and especially the FC part of the MABs. So that's why they are really popular here. In this, so that's why this type of chromatography is really used all the time when you want to purify MABs, therapeutic monoclonal antibodies. Sorry. Then the second step is the virus inactivation, because usually you can have virus on your, especially if you use the virus vectors to transfectate the host cells, so you still have virus, and to inactivate them, the purified sorry, there is two things with the acidic condition. You can just allow the elution of the MABs when they are captured by the protein A, and it's also allow the virus inactivation. So that's the first thing. But the problem here, you can see the first problem is that when you inactivate the virus, that could be in the media, acidic condition is detrimental for the protein, and they can lose their conformation. So, and especially MABs, who are very sensitive to. They are really sensitive to pH, acidic pH. Then the next step is the anion exchange chromatography. This step is to remove the DNA, most of the large part of the HSP endotoxin protein A. So you know what is anion exchange chromatography? It's okay for you. Okay. Then a cation exchange chromatography is performed to remove the other type of impurity. Then a filtration, because you inactivate the virus, but you have to remove them. Then the gel permeation to remove. I put here it's aggregate, but it's remove what we call the apparented form of the therapeutic protein. So that could be dimer, trimers, or truncated form. Just to separate them. Sterile filtration. And then you obtain at the end the purified bulk. But we have to keep in mind that all these steps could be detrimental for the protein. Even if you want to purify them, that could be detrimental for the protein. Why is because the protein, as you can see here, has to remain biologically active. She has to maintain her tertiary structure, so her folding. So, and this is to maintain the protein under the desired folding or 3D conformation. The protein is maintained thanks to the all-weak interaction, the all-weak intramolecular interaction, such as hydrogen bonding, electrostatic interaction, or hydrophobic interaction, as well as disulfide bonding. So this is covalent bonding, and here is non-covalent bonding. And the problem is when during all the process, the protein could be altered by different situations. For instance, if the temperature could modify the protein, modify the conformation. The ionic force, if you use, for instance, to eluate or to inactivate a virus, you use attends, je vais faire tout d'un coup. Hein? A buffer, sorry, je ne sais pas pourquoi j'arrive à faire. Thank you. Buffer, so with a high pH or with a high ionic strain, that could also be detrimental for the conformation of the protein because you're going to alterate, for instance, the electrostatic interaction. You have also surface absorption, because when they go through filtration or chromatographic column or whatever, they are able to bound to establish interaction that could be also detrimental for their conformation. They are sometimes reduced with stringent solutions such as area, SDS, or guanidine. So that's why, and what this leads to also covalent alterations such as proteolytic alteration, sometimes deamidation, oxidation, glycosylation alteration, isomerization. All these things will also have an impact on that could generate a different variant. Some of them will be okay, and some of them not. So that could be also a problem. So that's why we have really to keep this in mind, and that's why. Here to summarize what all I say, you have really here in this schematic figure all the pathway that could lead to physical instability of the protein and allow them to form aggregate and sometimes particles. So they can you can have unfolding. You can here is the native protein. You have structural and chemical change that could lead to unfolding here. It could also leading to small aggregate, and they can easily change their state very easily. So that's why you have to pay attention to this problem. And here, as an example, you can see. Here, for instance, in this figure, you can find a summary of all the physical and chemical problems that could happen to MABs, for instance, therapeutic monoclonal antibody. They can be oxidized on the methionine and tryptophan. And oxidation lead to so they are oxidate in these two acid amine, methionine and tryptophan, sorry. And this oxidation could also lead to conformational modification and render them prone to form dimers. That's really clearly identified. They can be also isomerized. You have also modification of the glycan level, lysine modification, deamidation, so really fragmentation. So many things that could happen for the MABs, and here you have all the methods that could allowing to identify all this the modification obtained. So to avoid this as much as possible, different type of formulation, stabilizing agent has been proposed, because so here you can see all the so here is all the problem, the parameters affecting protein aggregation. So I already listed them, but temperature, pH, salt concentration, protein concentration, or of the duration time of the process. But you have also all the mechanical stress that could have been done, because you have the freezing and the thawing that could happen. They are also stirred during the process. There is also non-mechanical stress. For instance, when they are exposed to the air, we know that the protein at the top layer on the air-liquid interface, we know that the protein who are at the top layer of the liquid are more sensitive, can be more hydrophobic, and then that could render them prone to form dimer as well. You have also all the interaction with the metal surface could lead to a problem of aggregation. So to avoid this, they propose stabilizer, such as osmotropic salt, detergent, osmolyte, sugar, polyol, sorbitol. You have also different chaotropic salts that could be as well used. So you have many. Here. So all the stabilizing agents are here. So cosmotropic salt, detergent, and osmolyte, such amino acids, such arginine, for instance, which is very popular. Some sugar, also you have all this polysorbate. So many things can be used for this purpose. So that's the way to prevent this problem. So then we have to, anyway, when the therapeutic protein is obtained, we have to characterize the protein and perform for this purpose a battery of tests. So first, so that is the beginning of the sort of quality control process. You have to identify their structure. That could be, you can test the primary structure to be sure that the composition is adequate. The secondary structure, the ratio between alpha helix or beta sheets, or if there is only alpha helix or beta sheets, depending on the protein, but it has to be controlled. The glycosylation analysis as well. And all the physical parameters such as molecular weight or isoelectric point. So the isoelectric point corresponds to the pH where the protein bears the same amount of negative charge and positive charge. So the global, at this pH, the global charge is neutral or near zero. Also verify the purity, as I said, so if there is the presence or not of O-cell purity, the fabrication process impurity, all the impurity related to the fabrication process, to the product-related impurity. So we have many types of impurities: host cell, fabrication process, or product-related, or impurity related to the product itself, such as unfolded, truncated, or aggregate. And the last thing is to check its activity. For instance, is they still able to target their binding? For instance, for therapeutic monoclonal antibodies such as infliximab, his target is TNF-alpha. So is the infliximab produced is still able to bind properly the TNF-alpha. You can test also its activity in vitro or in vivo as well. And also in terms of security, we have to verify the safety if there are still various particles are removed, and you have to check the presence of remaining genome or endotoxin detection. So that's why. So the viral security has to be. We have to check the viral security to verify that the virus is inactivated, eliminated, and control all these steps. So different type of virus can be present, such as endogenous virus, adventitious virus model. So different types of virus. And to inactivate this virus, we can also perform UV radiation, thermal treatment, or solvent detection, and then they have to be eliminated by filtration or steric exclusion, chromatography. So many things. And at least at the end, we have to check all this process has to be done in accordance with what we call the good manufacturing practice. So when we say G and X, that means good, G for good, practice for P for practice, and the X is for refer to all the specific area related to manufacturing, distribution, laboratory and clinical process. And for this, to check that everything is everything is under control, is compliant, you have to follow the guide of the International Conference Harmonization for Registration and Pharmaceutical of Technical Requirements for registration of pharmaceutical for human use. So you have harmonization procedure that allow to share common rule in EU, Japan, USA, or whatever in the four main domains, which is quality, safety, efficacy, and multidisciplinary model. So here is all the guidelines here. I'm not going to present all of them. It's just to know that this exists, and you have different specifications. So you have test procedure who will present all the acceptance criteria for biotechnological and biological products. And to set up and to establish rules concerning what we call the good manufacturing practice in the framework of quality control. So, and then, as a conclusion, I jump to the conclusion. So, bioproduction is really under a pharmaceutical regulatory concept that are adapted to living material use, and you have to define the critical point at the development of the early stage, especially when you consider the process is really complex, as you can see from the DNA to the therapeutic protein. You have many steps. The quality control has to be rigorous. We have, and also that's that have a cost, but it's a question of safety. But it's true that that the cost is high and the time is time consuming. I agree. But, and I think here you have well, all the, and now is, as a conclusion, a second conclusion, all this process has permanently optimized all the time. So it's never, so that's another thing to important. The next lecture I will present will focus mainly on quality control. So it's just as an intermediate. Here is the intermediate slide between today and tomorrow. I have prepared some questions as yesterday. No, they are easy. Do you have any questions? Sorry. Yes? Yes?
Primero de todo, muchas gracias.
Mm.
En una de sus diapositivas, donde comparaba las capacidades de cada hospedero, me fijé que en la sección de bacterias existía un tamaño límite para la expresión de proteína recombinante.
J'ai pas compris.
Dans une de tes diapositives, tu parlais des différents systèmes pour la production.
Oui.
Pour les bactéries, j'ai l'impression qu'il y a une limitation de la taille.
Oui. Yes.
Mucho más.
Ouais.
Très avant.
Oui, je sais, oui, attends.
Il y a une limitation del tamaño.
Sí.
Pero, tu saurais me donner l'ordre de grandeur ou pas de...
I have not I think it's below, but I have to check. I think. Ah, c'est pas.
Aquí está.
No.
Antes.
Ah,
No, sí, ahí. No, más adelante.
hein?
Non, d'abord.
Ah bon?
More,
Yes, I see.
que sería el- Era una tabla
C'est
comparativa.
un tableau.
Oui, c'est ça. Oui, ça, c'est ok.
Esta.
Tout par là? Non?
Esta.
No,
Oui, c'est
otra,
ça.
otra.
Un autre.
Esa.
Celui-là.
So that actually it's only for 60 or 70 kilodalton. Is that the
Mainly, it's below I think,
Kilowatt.
below 100 kilodalton normally. But I see it's more.
Por ejemplo, si yo quiero expresar
Mm.
variantes de anticuerpos, like nanobodies or single chains,
Ah, no,
¿puedo hacerlo
ok.
en bacteria y col?
Ouais, si tu veux faire des
Oui,
des
là
variantes.
j'ai compris, ouais, j'ai compris. Là j'ai compris. It's, this one, this time. Mais merci beaucoup. But you're not obliged. You can, if your first system of expression initially is for antibody is mammalian cells, you can keep the same expression host for a smaller version of your antibodies. You're not obliged to switch from one to another, because usually, for the antibody, for sure, we never use Escherichia coli to produce them. No, for the antibody, no. Usually, it's all the time mammalian cell.
Only mammalian.
Yes. But you,
Ouais.
because of the glycosylation.
Okay.
But if your system is not glycosylated, but maybe you can. But if you well mastered your expression system, I assume that it's better to keep the same. I don't know. Maybe if it's not so difficult, why not? But it depends. It's a compromise because you have something. You have to choose between something you well mastered, but sometimes you can need something who can lead to a rapid production. So it's a compromise that you have to.
Más rápido y menos costoso. Y tengo entendido que estos variantes de anticuerpos como nanobody.
Nanobody, it's smaller. Yes, they are not. I don't know for the nanobody. Probably not because the nanobody concerns the FC part and the glycosylation. No, the FAB part. Sorry, and the glycosylation is mainly of the FC part. So I agree I agree with you. It's not mandatory to use in this case mammalian cell. It's just the way. My concern is just when you master a system and you have all the tools dedicated to a system. If you have to change, sometimes it could take times, but it's possible because bacteria is quite an easy system to set up. I agree, but it's a compromise for me. But I agree with you. In this case, you have you don't have to take into account the glycosylation production. I agree, but it's other question? But thank you for your question. It's a good question. Tu as une question? You have a question? Okay. Well, I can. So it's me now. I have my question for you. So, well, I have less question than yesterday, but it's just so I can start. Okay, so we can. You are allowed to use your mobile if you want to participate to the question. C'est bon, c'est 10 heures. Est-ce que ça marche pour moi? On ne les voit pas, d'accord. Ok, you don't see it. Okay. Ah zut, il n'apparaît pas. Comment je fais pour faire apparaître? Oui, il n'apparaît pas. Non. Je ne le vois pas. Comment on fait pour apparaître? Sorry, I don't see the screen. I don't. Ah mince. Attends, je vais faire un truc. You can go to clap.com et je vais leur donner le code. Je vais faire une capture d'écran de ça.
Et tu peux pas?
Ben non, j'y arrive pas. Tu vois, je le vois pas. Alors, je sais pas pourquoi. Mais...
Ça avait fait comment
La dernière fois, ça avait fait tout seul.
Mais là, il voit plus ton écran du tout, en fait.
Enfin, il le voit, si, parce que tu vois, ça c'est moi. Mais. Ah, peut-être ça, là. Attends, regarde en bas, là, si tu mets comme ça, en plein écran. Non, ça pas. Ou sinon, ce que je fais, c'est que je copie tout ça.
Attends, mais il est pas là,
Non, attends, j'ai fait autre chose. Je fais une capture. Attends. Otherwise, I can do. Voir ce que je faisais. Ok. Ah, ça oui. Ah oui. Quel boulet. Ok, thank you very much. Le boulet, c'est moi. Ah oui, tiens. Oh, here you can play. Enfin, you can play now. Okay, I start. So, first question. Attends, comment je vais dire? Oui. What is a recombinant protein? Okay, so the correct answer is a protein produced by genetically modified organism. Okay. Which ce que j'ai fait? Ah merde, sorry, I made a mistake. Sorry. Well, okay. So anyway, I think you know that the most commonly used both for recombinant protein production remain bacteria. Si je sais plus jouer. Attends. Which system is preferred for producing complex human glycoproteins? The correct answer is mammalian cell. Okay. For bacteria, you can't. There is no glycosylation. What is the main role of a plasmid in a recombinant protein production? The correct answer is everybody is good. Gene delivery vector. What is the function? What's the function of the DNA ligase? I just talked about that once. So. Okay. Okay. So the correct answer is yes. You join DNA fragment. Which step ensure high yield of recombinant proteins? The correct answer is yes, fermentation bioreactor cultivation. That's how you scale up your production of proteins. That's the last question. Which of the following is a therapeutic recombinant protein? So the correct answer is insulin. Okay, that's the first. Well, it was the first therapeutic recombinant proteins. Okay, so it's finished. I finished my lecture. Thank you very much for your attention.
¿Ya hubo un problema con el coffee? Sí, así que he estado así que va a comenzar la segunda charla y me vienen a avisar cuando finalice esta cosita y ahí hacemos un alto. Pido disculpas, pero es algo ajeno a nosotros. Pero va a ser, espero 20 minutos, no más.
C'est pas encore prêt.
Non, le café n'est pas encore prêt, ouais. Et du coup,
Hervé commence.
il va commencer, je vais...
Moi, j'ai fait 1h30 à peu près, je crois. J'ai fini trop tôt.
Ça qu'il avait mis dedans. Tu vois, j'ai pas assez mangé ce matin, j'ai faim.
Ah, t'as faim, ben voilà. Donc, on n'a peut-être pas mangé tant que ça hier soir. Moi, j'avais faim ce matin en me réveillant. Ah merde, ça se trouve, je suis très prête. J'ai gardé le truc. Ah, je sais faire en espagnol.
Oui, je sais pas si vraiment besoin d'un micro. Non, c'est Hervé. T'as compris comment fonctionnait le truc là?
S'il est toujours en route ou ça va?
Le micro marche. Par contre, j'ai pas compris comment ça va.
Ah ouais, ça
Là, il faut ton mot de ça. Comment ça va, tata? Ah non, ça va. C'est pas pour le goût du CNRS.
Comment?
C'est pas pour le goût du CNRS.
Mais oui, enfin, on l'a pas.
La charla que debería comenzar a las 9:30. Y partimos este bloque con ruta pulmonar. y va a partir del B hablando sobre liberación de fármacos en la vía pulmonar.
Okay, can you hear me? Yep. So, buenos dias. Good morning, everybody. So we'll start with an overview of pulmonary delivery with a focus of innovative form. However, I will also briefly present you the conventional delivery form for pulmonary delivery. And then my colleague Nicolas will focus on the most innovative form, relying not only on nanoparticles but on specific particle engineering. So let me start with, it's for 1 hour, right? We planned for 1 hour. So feel free to interrupt if you have questions, as always. Just to start, to begin with, a rapid overview of the respiratory system. In the case of pulmonary drug delivery, we have really a lot of very specific features of both the formulations and the devices that you need to use for the formulations delivery. And dealing with the respiratory system is also quite, I would say, different from all other delivery routes, and you really have to take into account the specificities of the lungs, of the tissues that you are dealing with. So if you take a look at the respiratory system, you have the upper airways, which are actually extrathoracic, and then the lower airways. So don't make a confusion with nasal delivery, okay? We won't be dealing with this. Actually, nasal delivery is different because you're dealing with different, dealing with a mucosa. You're actually not going very far, not very deep in terms of aerosol delivery. So actually, in terms of formulation, it might be a little bit easier in terms of aerosol formation. The devices you find are actually, small pumps, not very complicated actually. But then the tissue itself, the mucosa, is quite complex, and the applications, especially in terms of vaccination, are not so easy, right? But if you're dealing with the lungs, it's totally different. Now you're producing an aerosol that really needs to be finely controlled, so that the aerosol itself that you want to deliver really goes into the lower airways, the bronchi, and the alveoli mostly. The tissues actually you are dealing with are also quite complicated, and they change over the course of the journey throughout the pulmonary tract. Actually, if you look at what's happening in the bronchi and bronchioli, you see that you have this epithelium, which is composed of epithelial cells, and this epithelium is actually surrounded by a mucus, which is the gel. It is a gel, okay, in terms of physical chemistry. Within this mucus, you have some periphery layer, which are actually small stuff that help moving the mucus, and this has a big role in the elimination of the particles that may be trapped within the mucus. It is also interesting here to see that it's a different story if your particles, or what you deliver, we'll see that in a minute, are located and stay within the mucus, which in this case they might be eliminated by the mucociliary clearance, or if your aim is to deliver something directly to the epithelial cells. For example, let's say you want to deliver this RNA, mRNA, whatever. If you want to perform some gene delivery, then it means that what you are delivering really needs to go through the mucus gel and not stay within the gel, and then be taken up by the epithelium cells. So that's for what's happening in the airways, okay, until you reach the alveoli. And then in the alveoli, it's a different story. You know that the alveoli are actually the place where the gas exchange really occurs. It's a huge surface of something like 80 square meters that are actually packed within your thoracic cage, which is quite impressive, right? You have a tennis court which is really folded within your lungs. And this huge surface is aimed at, or is actually works for gas exchange. Okay, this is an explanation. And if you look at the structure of the epithelium, it's actually different from what you find in the airways. You have different types of cells, okay, and you have you don't have the mucus, but you have a lung surfactant layer. And you also have other cell types, and this is where you will find some alveolar macrophages, for example, which are relevant for drug delivery. Now, the respiratory systems works, of course, primarily for respiration, and these are the parameters that you need to evaluate the efficiency of your drug and your drug formulations. First, the different volumes of your lungs. Okay, you have the total volumes, the vital capacity, and the tidal volume, which is the small fraction of the volume that you may use right now, for example, then you're seated, so you're using just a small fraction of what you can use. But if you're doing some exercise, or if you are undergoing an evaluation of your lung capacities, then you may be asked, to breathe in as much as you can, and then breathe out as fast as you can. And you can measure what we call the FEV1, which is the maximum volume you can breathe out in the first second. And this is quite used for the evaluation of the drugs. Then another actually function of the respiratory tract is also to eliminate the pollution the particles that may be trapped. And actually, when I'm presenting this in Paris, I'm using the example of pollution, which I may not be using here. You have some clean air here in Concepcion. But in Paris, we have more pollution, and so many particles, okay, that may be trapped in your airways. And again, if you're located in the airways, in the bronchi, for example, you have these mucociliary clearance mechanisms, which are it's pretty amazing, actually. Those small, actually, cilia. They work in a way that the movement actually is only in one direction, and this direction is towards the exit, the entry of the airways, so that the particles can be then swallowed. And to do that, the cilia have this kind of movement, okay, in this direction. It's like a tide, if you want, in your on the beach. And this allows to have always this unidirectional movement. And then if your particles arrives in the alveoli, then it might be taken up by macrophages, okay? And that's a slower elimination phase. But again, this is natural defense mechanisms that we can take advantage of when we are doing some drug delivery. So let's see now what kind of aerosols we can design for pulmonary drug delivery. Okay. Yeah, no problem. No problème, no problème. Ouais, très bien, très bien. Parfait. Il n'y a pas de souci. Sí, exactement.
J'ai oublié de lui envoyer le document signé par Zoé, comme elle a fait. Ça fait longtemps qu'on l'a signé, j'ai oublié de lui envoyer. J'ai reçu le 6 de
t'avoue, j'étais un petit peu concentré sur le truc parce que je viens juste de récupérer. Ça y est, j'ai eu S-Drive et du coup, ça y est, j'ai pu reprendre toutes mes présentations et j'ai vu un truc un peu.
Oui, mais t'as raison.
Mais non, 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 ça va, mais je me dis, il faut que je me suis dit que j'avais beaucoup de choses à apprendre en fait, cette présentation. Et j'ai trouvé dommage de ne pas avoir, de pas être plus concentré, tu vois.
Oui, non, mais c'est pas grave. C'est intéressant pour eux. Je suis contente, j'ai une question.
Mais ouais,
c'est pas idiote.
Ouais, et puis alors je t'assure que vraiment tes book labs, c'est vraiment génial. Hein.
Ah oui.
C'est tout bête et enfin c'est tout bête, c'est pas tout bête, mais je veux dire.
Mais ça permet de détendre et de reprendre des trucs. J'aime bien le faire.
Ouais, non, non, mais franchement, c'est vraiment
Je
top.
pas faire beaucoup plus. Là, j'étais un peu rapide. Je parlais trop rapidement au départ. Après, il a fallu que je me.
Non, c'est vraiment parfait. Jusqu'à 11h30 du coup. Ouais, 11h30. Ok. Ouais, mais je sais pas si ça marche. Je pense que c'est lui qui n'a pas dû être activé là-bas. Can you hear me? Yeah? It's working? Ouais, okay, gracias. Okay, so we've seen the general features of the lungs and the different structures of the epithelium that you need to take into account when you're doing a drug delivery to the lung. Let's now see how you design exactly the formulations that you will administer to the lungs. And first, just the framework is given by the European Pharmacopoeia. When you're doing some preparations for inhalation, you can aim at a local or a systemic effect. You can use some multi-dose or single-dose containers, and you have three major types of delivery strategies that I will describe now. One important thing is I will focus now on aerosols. Actually, you can find some more, I would say, historical or actually older formulations consisting in liquids that will be converted into vapor, okay? But when we say vapor here, it's really vapor in a physico-chemical sense. That is a vapor phase, a gas phase, okay? So that can be, for example, essential oils, you know, in some organic solvents that will really be converted into gases. Most of the time we are dealing with aerosols, and by aerosols we'll mean some very specific term, and these aerosols can be delivered by three major types of devices: nebulizers and pressurized metered dose inhaler in the case of liquid formulations, and powder for inhalation with specific devices. But what does an aerosol mean? Actually, an aerosol, by definition, is a dispersion. So you have two phases. One phase which is dispersed, that can be either a liquid or a solid, and one dispersing phase, which in most of the cases is just air. In the dispersed phase, so you can have a solid that you will need at some point to, you know, produce so that it is really dispersed, or you can start from a liquid, and again you will need to find some way to really disperse it. But it's important to have in mind that those dispersed phase, like those small, you know, particles, liquid or solid, can themselves contain smaller things that can be either dispersed, dissolved, or can consist sometimes even in nanoparticles themselves. But what is the size of these aerosol particles? So the size of the particles is really important and makes a huge difference for the deposition. Because don't forget that when we inhale something, we really need to understand how the particles will be, you know, transported throughout the respiratory tract, so that they don't get stuck in the throat, for example, and they really reach the bronchi or the alveoli. And to really finely tune this, you need to understand how the particles will deposit throughout the respiratory tract. They can be deposited by different mechanisms. Let's take this one, which is maybe the easier to grasp, the sedimentation, when particles just fall down by gravitation because of their weight, and they meet at some point, you know, an airway border, and then just stay here. So you understand here that what will be important is the weight of the particle, which means the density and of course also its size. Another mechanism of deposition is what we call the impaction, and that means when the particle really is in high motion, at some point, if you have let's say, bifurcation of the airways, the particle may quit the airflow and just hit the particle just, under the influence of its own inertia, which means in this case that the velocity and also the mass of the particle is important. And finally, you have a last mechanism which is called diffusion. It's not really a deposition mechanism, even though it is often mentioned in this here. But actually, it means that the particle will remain within the airflow by just diffusion mechanism. And if you're in a region where there's not a lot of velocity of the air, for example, in the alveoli, then the particle has some chance to deposit at this point. But if it is just in the throat, for example, where you have a high air velocity, then the particle may just be expelled. So if you combine all of these together and try to use this phenomena to really design your aerosol, then actually the main take-home message here is that the size of the particle of aerosols should be above 1 micron, and this is usually what we aim for, because this is where you can really take advantage of the sedimentation and impaction deposition mechanism. If you try to inhale too small particles, then they will just remain within the airway and the airflow and by just diffusion. I won't go into this region because it's actually quite challenging and we don't really know what's happening, but for very small particles, you can have other types of deposition mechanisms. But here you are located in the nanoparticle region, right? It's below 0.1 micron. And that's an important point, by the way, for a nanomedicine perspective. And Nicolas will discuss this later. But if you want to administer nanoparticles by the lungs, that's very interesting for many therapeutic purposes. But you cannot just imagine to have nanoparticles dispersed as an aerosol, right? I don't know if I can use the board. Is there a... No? There's no pen? Oh, it's okay, don't worry. Oh, yeah? That is. So aerosols are really, either a solid phase or a liquid phase dispersed in a gas phase. And we say, okay, this should be above 1 micron. Okay.
You can use the red one, please?
The red, oh yeah, sure. Wire, okay. So those particles, of aerosol should be above 1 micron and can be either solid or liquid dispersed in a gas. Okay. So we'll see how we produce this. But if you want to administer nanoparticles, well, actually those can be here. If it's a liquid phase, it will be a nanoparticle suspension. And if it's a solid phase, it will be nanoparticles embedded within a solid matrix. Okay? So important to have this order of magnitude in mind, and just don't imagine that we can disperse nanoparticles directly in the form of an aerosol. Usually that doesn't work. Nanoparticles don't like to be really dispersed in this. And another parallel that you can draw is with pollution, right? You know that if you look at the quality of the air, usually we use the term of particulate matter 2.5 and 10. And 2.5 and 10 refer to microns, not to nanometers. Okay, so this is what we can say for the size of the particles for an aerosol. But don't forget that we say the motion and the weight are important, which means also the mass of the particle, which is why we also need to take into account the density. So size and density. Actually, it's becoming a little bit difficult to have too many parameters to combine and to compare aerosol types. This is why we use one parameter, which is called the aerodynamic diameter. And this diameter is actually different from the conventional diameter. If you look at your particles under the microscope, you will actually measure a diameter, and this is what we call the geometric diameter. And this is what you can measure, for example, by also diffraction. And actually, this geometric diameter can be corrected actually with this parameter, which is the square root of the density of the particle. And that allows you to have this new parameter, which is aerodynamic diameter. And to understand why this is interesting, I here give you two examples, two very different examples. The first one I call small dense beads. Those are 2 micron beads with a density of 1, which is the same as water, but you can imagine it's a solid, okay, pretty dense. So in this case, the aerodynamic diameter is 2 micron, and that could resemble this kind of thing. And then take another completely different case where you have a large particle, but poorly dense. This is what we call, for example, large porous particles. If you have a higher geometric diameter, but a much smaller density, well, in this case, you have the same aerodynamic diameter, which means actually those two particles, because they both differ in size and density, they can deposit the same way. And this is, you understand why this parameter is then interesting for drug delivery purpose. Because then you can really anticipate, you can plan for the deposition pattern of your particles as a function of the aerodynamic diameter. And the smaller the diameter, the deeper the deposition in the lungs, which has some important consequences for the action, the therapeutic action you want. If you have, in general, we say some diameters above 3 micron, you can think that you will stay within the lungs, the bronchi, if it's below these sizes. And if you manage to make an aerosol below 3 micron and still above 1 micron, okay, so in the range of 1 to 3 microns, then you can expect to reach the alveoli, and this is where you can hope for a systemic action. I say hope, why? Because if you want to really have your drug's molecule reaching the blood, then you first need to have your aerosol particles deposit in the alveoli region, and then you need also to have a passage of your drug molecule throughout this air-blood barrier, which is the epithelium in the alveoli, which is not always the case, right? Which is why I said that you have a potential systemic activity provided you reach the alveoli, okay? Now, those sizes are actually not fixed and rigid ones. We are dealing with a complex tissue, a complex organ. And for example, on this empirical model of deposition, you can see that, okay, 1 to 3 micron is an average, is maybe the optimal, but it doesn't mean that 100% of the particles will go in the alveoli. You have deposition, of course, in the other regions. Sorry. This is something we can measure by using this type of devices we call impinger that we have in the labs when you want to really characterize an aerosol system. And with using this, you have actually here a complex air circulation pathway for the aerosols, and you can determine an average aerodynamic diameter. And the fine particle fraction can be usually measured this way, and is in general considered to be below 3 microns. Then if you want to study the particles themselves, again, I mentioned microscopy, but usually laser diffraction is a more rapid way to measure this type of geometric diameters. So that's for the aerosols, okay? But remember, the pharmacopoeia tell us that you have some liquid preparations, the solid preparations, and they should be also, broken down as a function of the delivery device. So what are the delivery devices that you may find in this field? Well, first, this one, which I'm sure you have already seen because it's quite common. This is what we call the metered dose inhaler. I don't know how you call this in Spanish, but we have several terms. ¿Cómo se?
Inhalador de dosis fija.
Okay. So this is the name of the device. Okay. And it's quite common because it's usually an affordable one, very convenient to use, to have in your pocket when you need a bronchodilator. But actually it's a complicated one if you look at really the physical chemistry and the formulation behind. And there are also some improvements that can be done. I will show you this in the next slides. But that's for a specific type of liquid. Then we also find the nebulizers for the conventional liquids. So this is of course something which is much bigger. You will find this more in hospital, and this works with a mask usually that you need to take with you. In terms of formulation, it's easier because you can deal with many liquids. And let's say you have your liposome, innovative liposomes form. You can produce easily liquid out of this, and you can imagine that this will be nebulized pretty efficiently. However, it comes with several drawbacks, such as the cost, the inconvenience of the system, and also the fact that it's mainly used in hospitals. Sorry. Then I will take this one, okay, and then come back to the third one. But dry powders inhalers are really the technique that the device you use to deliver the powders, okay, so the fine powders. There are some advantages because compared to the MDI here, it's quite easier to administer because you don't need the synchronization between the inhalation and the triggering. But it can be sometimes a little bit harder to breathe in. You need enough breathing capacity to use this kind of device. And then the last one, which is actually a bit in the middle, it's an innovative form. It's what we call the soft mist inhaler. Which shares some characteristics of the nebulizers because you start from a liquid form, okay, and it also shares some characteristics of the MDI because it's quite portable and easy to use by the patient. But still, you need some coordination, even though it's a little bit easier. But it's not yet doesn't combine all the advantages. And right now, we can see only a few proprietary devices. But those are the main ones. So how do you then use those different? In which cases do you use those different items? Well, actually, the nebulizers are usually come as a compressor, okay, and I told you with a different mask. And this is something, again, not much to say in terms of formulation because it's quite conventional. You need a liquid, and you will nebulize this liquid as a function of its own physicochemical properties. Then the MDI is actually interesting to understand how it works from a physicochemical point of view. It's not a compressed gas, actually, in which case, let me see. Okay, it's not a compressed gas in this case where you have a liquid which is, actually transformed into, which is nebulized because you have some pressured air above it. This is actually the older form because the efficiency of nebulization will decrease over the time. Instead, we use some liquid gas. It means that actually this substance is, this chemical compound is liquid only when it's under high pressure. And it's a gas at normal temperature and pressure. And here, this liquid is converted into the gas only when it is transferred into the conventional pressure and temperature. The interest, though, is that here the vapor you have above in the canister is constant. It's actually the saturation pressure. So that's why this leads to a homogeneous generation, aerosol generation, over the whole use of the canister. And so that's the principle. And then practically, this is how it works. You press above and the canister is upside down and the mouthpiece is here where the aerosol comes out. This relies on the use of liquid gases, and that's maybe the weakest point of this system. Before, we used some chlorine-based liquid gases that have been banned now some time ago and replaced by the fluoride-based liquid gases that are still still a problem today. Interestingly, this was banned because of their effect on the ozone layer, which was a huge environmental concern when I was young, and because this has been banned, now the ozone layer is the hole in the ozone layer has been, let's say, the problem has been solved. Today, HFA is a problem because it's considered as a greenhouse emitting greenhouse gases, and the problem is still important, and I think we'll need to find some alternatives to this. Okay, so in terms of formulation, this is more complicated, and again, this is a very convenient device, widely used. You have maybe some of you in your pocket, but the pharmaceutical formulation is quite complex, and you need this propellant, co-solvent, surfactants for different, different application and different roles, and all of them are needed in the whole formulation. And interestingly, for example, when we moved from the CFC to the HE phase, well, actually looked simple, okay, from a regulatory point of view. You need just to replace one propellant by another propellant, but actually when you look at the physical chemistry behind, it's complicated because you cannot use the same excipients that may be not soluble. The ebullition temperatures also are different, and this is why you need, for example, to play on the canister and the device itself to get rid of some surfactants, and also to treat and seal differently. But it works, and that's, I think really, really interesting to see that when you when you move from one system to another. Actually, look at this. We'll discuss a little bit more of quality control tomorrow with Claire, or the day after tomorrow, I forgot. But just to give you an overview of how it works in this in the field of pulmonary drug delivery, this is the amount of drug delivered, throughout the use of device, and you can see that although the system is quite complicated, it's exceptionally regular. Okay, this is really, really efficient, and we are talking only about milligrams, and that's a great success, And it falls very rapidly, and that's an advantage over the pressurized or the pressure gas, that I showed you before, because here it's very rapid. It drops suddenly, and that tells your patient that okay, this is over. Whereas if you have a progressive decrease, then it's not good in terms of dose homogeneity. So let's now see how the powders work. For the powder, the story is completely different, right? Because you have to start from a powder and not from a liquid. You need to really adapt your device to these needs. And you can see many devices actually on the market, from single dose to multi-dose systems, and disposable ones to other systems that you can reload. But to look at them from a historical point of view, actually the first interesting and well-used systems were this type of DPIs, where you could load, actually they come with a blister of capsules filled with the powder, and you load actually a capsule inside the DPI, close it, and then you press those two buttons to make a hole in the capsules to allow the powder to be released, and then you just need to breathe in. So the interest here is that your breath is triggering the administration, which is a big difference over the MDIs, where I don't know if some of you have used it, but it's quite challenging. You need to make a coordination between the triggering and your breath. In this case, no need to coordination, it's more efficient. And from this, actually, many multi-doses devices have been developed, and they can be more or less efficient. And how do you evaluate this efficiency? That's important, actually, and that's a challenge in the field. If you look here, just as the amount of powder that is recovered after the administration, this is what we call the fine particle fraction emitted, really the amount that will be relevant for a therapeutic purpose. You can see that it's actually pretty low in some cases, 10%, not big, not great. And in best cases, it's around 50%, but it's still something that you really need to take into account in terms of a dose delivered to the patients. One important thing to understand here, and I'm progressively switching towards the different clinical application, is that the control of the dose delivered is really key in the case of pulmonary drug delivery, especially when you're dealing with bronchodilators, because the dose we're talking about are milligrams, okay? And I don't know if I think you realize what milligrams are, right? If you were to be weighing milligrams, you wouldn't be really happy, right? It's very, very small, a small amount of powder. So how do you ensure that your patient, with all the complexities of the formulation, the device, and how the patient will use the device, it's quite challenging to ensure that you will be delivering only a few milligrams, not more, might be toxic, and not less, no use. Well, you need to really, really control how you'd make a dilution of your API with your excipients, and you have several ways of performing the dilutions, either a random dilution, or what we do now to really control the things is what we call controlled blends. It means actually that we are blending API with some very well-controlled excipients that we call carrier lactose particles. You can buy them, and they are really well controlled, and they have a defined size, well suited for pulmonary administration. And if the blending is correctly done, you can have an ordered blend, which means that actually the amount of APIs that are adsorbed at the surface of these particles. And then, upon administration, this blend should be correctly controlled, so that by controlling the different forces throughout the administration process, you might have a correct deposition of the API and a correct control of the dose. And again, this is crucial when you deliver some small doses. This is, for example, a photo of this, deposition of the small APIs particles on the lactose particles. And several formulation strategies have been developed over the time to really improve this, such as, for example, the addition of anti-adhesion and anti-friction agents, and also the addition of very small particles to really help the flow and the deposition. And today we are reaching some very interesting deposition efficiency. For example, with this device, if you compare, you have some, more than 60% of usable fraction of dose, and more importantly, they do not depend, or not so much depend, on the air flow itself. And what does this mean? Actually, this heterogeneity means that a patient that has a good breathing capacity will have a good dose delivered, but not always if you are not in this case, okay? So that's actually really one of the very interesting today outcome. And again, if you look at the doses, they are here in micrograms. Okay, so that was, how you can do some conventional formulation today by using these control blends, and this is really what is done in the industry, and a very conventional way to produce solid aerosols. But now, what's happening if your goal is to do some innovative forms with, let's say, nanoparticles, for example, then you need to really control the way you're doing your particles. And I'm just here giving you the principle of particle engineering using a technique that is called spray drying, and Nicolas will discuss this now after this. But just to give you the principle here, to produce a particle with some design features in terms of size, in terms of density, of porosity, then you cannot just you buy an excipient. You need to do this, and in this case what you are doing is you're producing, nebulizing a liquid. So this liquid contains your API and your excipients, and it is nebulized as small droplets, and it is very rapidly dried in this chamber by using a hot airflow and recovered here in this separation mechanism, and you end up with particles with desired features. Okay, so that's how you can really engineer your particles. So now, in terms of applications, I will focus on local and systemic action, depending on what you want to do. And I've already actually covered the main application, because it's what I showed you when I gave you the example of bronchodilators, and how you need to really control the small doses that you will deliver to your patients. And that's important for the management of asthma and also COPD, which is gaining a lot of importance in many countries. And well, actually here the strategies in terms of formulations are quite similar. We are using some, most of the time, the same molecules and the same delivery strategies. But then you also need to deal with infections, right? Viral, but most of the time bacterial infections. And in this case, actually, it's interesting to note that the delivery strategy may really differ. And why? Because actually, when you are delivering antibiotics, for example, then the problematic in terms of dose is the opposite. You're not delivering micrograms of a drug in which you really need to control that, okay, be careful, it has to be efficient, but it shouldn't be toxic. Well, in this case, actually, the doses are much higher, and you need to achieve some concentrations that are above the minimal inhibitory concentrations. And that's the whole different story here, okay? So how do you do that? So several possibilities. You can start with a liquid form. So this is an example, quite old example of a reformulation, actually, of tobramycin. Tobramycin is a liquid form. It used to be injected, but came with a lot of side effects due to systemic exposure. So the more, I would say, direct formulation strategy is to take a liquid and to make a nebulization out of this. And here's an example of how you can control the nebulization conditions to ensure that you will deliver this mostly in the lung regions, and especially in the bronchi, and not too much in the alveoli, because here the interest is that you will avoid a systemic exposure by minimizing the amount that you put in the alveoli. So this works pretty well, and you see that you decrease the nephrotoxicity here. And then also you can do the same with DPIs, and here the interest is that you can also, provided you formulate your powder in good conditions, you can also achieve some important doses delivered to the patients. This is one example, but I don't know if you show it, Nicolas. No. So this is a capromycin, which is a very relevant drug for TB today, and especially for resistant TB. So you see that this is really an example where you need to achieve some relevant concentrations that are high enough to be delivered in the lungs. And those particles are produced by spray drying, so the last technique I showed you for the powder preparation. And the interest here is that you just need, if you want, to use this one excipient, leucine, that has some good drying properties, actually. And by playing on the spray drying conditions, you can produce particles using a minimum amount of 50% of excipients, a maximum amount of 50% excipients, and as low as 10% excipients, which means that in this case, you're producing particles that contain 90% of API, which is really relevant for anti-infectious drug here. And then, of course, the particles may not be exactly the same, but Nicolas will tell you how we are producing these really, really funny shapes of particles. It's quite funny. And that's okay. That's interesting. Here a feature is that using this type of formulations, you can achieve some really interesting amounts and concentrations in the lungs and still decreased some systemic exposure and therefore decreased the side effects. Okay, and here this is also just to mention that even though it's pretty old now, but Nicolas and I, we both work with this actually NGO, which was actually focusing on providing formulations with, you see, pretty advanced delivery technologies, but aimed at populations that could not afford some very expensive treatments. And this was promoted by the Bill and Melinda Gates Foundation to try to propose new formulations to the developing world. And yeah, I wanted to mention this because it shows you that we can do some advanced delivery technologies still for people who need it. So now, just one or two words about systemic action, because pulmonary delivery is relevant also for proteins. We've seen how proteins can be produced with Claire just before this, and it's important to know that actually this has been also investigated for the pulmonary administration. Why? Because actually the epithelium in the alveolar region is pretty different from the epithelium in the intestinal region. You can have some transport mechanisms that differ from the oral route. And this is known because actually some small molecules are known to pass through this epithelium, okay? But actually this has been proposed as an alternative delivery route for insulin. And this is this is an old idea due to the fact that by pulmonary delivery, there is some passage of insulin throughout the epithelium, which is not the case for the intestinal epithelium. This is why you cannot have some oral forms of insulin, of course, and this is why people need to inject today still the insulin. So this idea actually has been investigated for quite a long time now. There has been, different players here that have pushed this idea forward, and this idea really had a rationale of, some, I would say, efficiency, both in terms of PK after delivery to the lungs in preclinical study and effects on glycemia also. And you can see here even a prolonged effect compared to the subcutaneous administration of insulin, even though in both cases you have the absorption step, even in the subcutaneous administration, but still you have here a more prolonged effect. And this actually has been really the formulation and the device that has been the more successful in the insulin delivery field. It's actually, I don't have it with me, usually I try to have it, but it's this type of device, okay, this size that you can carry with you. When I show this to my students, they always tell me, oh, it's quite cumbersome, it's not convenient, it's a big one. But, well, this is an alternative to injection, right? And it looks, I think, at least for the people who are in the field, it looks promising. So this consisted in this actually inhalation chamber that you can deploy from the device, And the formulation itself was insulin with a few excipients only for pH adjustment, a pretty simple formulation. What was complex though was the use of this. You know, the use was pretty complicated. You have many steps to perform, and before and after. And actually, even though it looks very promising, Pfizer spent a lot of money for that, a lot of money to produce the insulin first, because don't forget that you need to administer much more insulin in this case, because the bioavailability is only about 10%, okay? Which means you need to administer 90% of insulin that won't be useful for your glycemia. And one of the problems was that actually we don't really know what was happening with those 90% remaining, okay? And actually, even though there was not clear conclusions on that, there was still some concerns about the elimination of these big amounts of insulin that was not transported throughout the epithelium. There was actually, I think, a few lessons also to learn from this, because we didn't make the life of the patient pretty easy in terms of dosing, in terms of access to the treatments, because, for example, people needed to take a breathing test to ensure they could inhale this correctly. And it turned out that actually the physicians themselves were not so eager to propose this to their patients. And there was even a concern regarding the emergence of several lung cancers in a big clinical study, which were not really connected, you know, to the use of inhaled insulin, but there was a concern big enough that actually very rapidly after the introduction of this, it was withdrawn from the American market. Only actually one survived, which was this technology with a higher bioavailability, and it was actually, there was a second chance that was given to this company, and in France there was Sanofi who took this technology. You see, it's a much smaller one, looks more convenient, but actually it was also withdrawn from the market quite rapidly after its introduction. So why am I telling you this failure actually? I think to me it's a very interesting story because even though it was not a commercial success, I think it really shows how you can, by playing just on the formulation and also the device, you can really propose an alternative delivery route. And I think proposing an alternative to daily injection is obviously a great thing you can propose to patients. So I'm sure we'll see more of this in the future. So now just one or two words about how we can make further innovation. So actually there is some potential of the pulmonary route for vaccination, okay? Even though there are not right now many things that are really advanced, but I think it's good to imagine that this can be envisioned in the future, and we have a few data for that. For example, one experiment that was performed by the WHO on the measles vaccination of Mexican children. Actually, this was a more convenient way and a more an easier way to vaccinate many wide populations, and actually the outcome was pretty successful. I think this is one good idea to keep in mind. And it was also investigated for TB using the spray drying as a technique to produce solid aerosols of bacteria, which is, you know, in terms of concept, a really new concept that was proposed by this team some time ago now. There has been also investigation for the COVID vaccines. And even though immunization is a complex system, is actually a complex system that occurs throughout using the whole immune system of your body, but still here the rationale consists in performing the administration using the same route of exposure, okay, which can be both applied to TB vaccination and also to COVID vaccination. And now just one quick words to make a transition with the next lecture by Nicolas, is how do you use the pulmonary delivery to also propose something for innovative forms? Well, that's really the case with nanoparticles. Nanoparticles still, can be interesting for pulmonary delivery. They could be, a system to allow a reservoir system if you manage to keep them long enough in the respiratory region. And they can also have some promising targeting properties. And this is the case if you look at those cell population, the macrophages. Macrophages can be especially a reservoir of the TB infection, latent TB infection. And it could be interesting to have nanoparticles able to target them the same way I presented the first day, when I showed you the delivery of nanoparticles. However, doing this is difficult. If you remember, I told you that aerosol particles usually are above 1 micron. Otherwise, it's very difficult to produce an aerosol out of this and difficult to control also the deposition. So you need to imagine a system that will allow to administer nanoparticles in the form of something bigger. And Nicolas will show you that. I'll just show you one example of something we've done in the lab, which consisting actually in formulating nanoparticles with some mannose residues at their surface to make some targeting of alveolar macrophages. And to do that, actually, we use mannose because we knew that mannose had a big affinity for a surfactant protein that is located in the alveolar region. And we expected actually those particles to capture this SPA, which then was expected to promote the uptake by the alveolar macrophages. We designed nanoparticles that were able to take up this SPA in vitro, and after exposure to cells, we've shown that actually the macrophages tend to take up these nanoparticles when you put SPA. And we even made one assay in mice that were nebulized with these nanoparticles. So this is, something that would be like a nebulizer for clinical studies, right? We only take the nanoparticle suspension as a liquid and we nebulize it, okay? So that would be, in clinics, you will use a nebulizer and a mask for a patient, but this is how you do the preclinical study in the mice. And we have shown an interesting uptake also in the macrophages recovered from the lungs. Okay, so with this, I'm actually wrapping up and showed you how we can start from very conventional formulation, how you can control really the small amount of APIs you deliver or bigger dose you can deliver. And also by doing some more and more complex system, we can also today imagine that we administer nanoparticles to the lungs. Do you have any questions? No? No. Okay. Okay, then we'll switch to Nicolas. Thank you. Et ensuite, si tu mets ton... Si tu mets ton... Can you hear me without the microphone? Okay. So now I will go ahead with the rest of the lecture on the lungs. I'm going to show you how we can spread dry pharmaceuticals for optimal delivery to the lungs in order to obtain dry powders. And I will spend a little bit of time to focus on what's happening in the spread area, how we can model what's happening with spread area. Okay?
So, as Hervé said, for pulmonary routes, we are much interested in the role of aerodynamic diameter. So basically, if we have particles with aerodynamic diameter that is defined as Hervé defined it here, between 5 and 30 microns, they will deposit in mouth, throat, and trachea. If you have something between 3 and 5 microns, it will deposit in the bronchi and bronchioles. And if you want to reach the alveolar regions, you want to have aerodynamic diameters below 3 microns. So as Hervé already presented, because of the role of the density of the particle, this is rho and not r, large particles with low density and small particles with high density will have approximately the same aerodynamic diameter and will deposit in the same region of the lungs when you inhale them. Except that the large particles with low density, they will be much easier to disperse in the dry powder. So most of the time, these powders are prepared by spray drying. Spray drying is the fast drying of droplets obtained by atomization of a solution or a suspension. So this is the spray dryer. We start with the excipients and the API in the container here. Then there is a pump, and it reaches the nozzle. The nozzle is connected to compressed air, and the compressed air is atomized into small droplets. And because we have aspiration, the droplets are dried very fast, and they will end up in this cyclone, and the cyclone will separate the air from the particles that will deposit in this container. So for those who are doing spray drying, you know that you have very, very different morphologies that you can obtain on the particles after you spray dry them. You can have spherical particles, wrinkled particles, hollow particles. So what we know is that the morphology is linked to the delivery and release properties. And when I was doing my postdoc a very long time ago, we wanted to understand better what was happening during the drying process and why in some cases you end up with spherical particles that are very dense, and with some formulation you end up with hollow particles or wrinkled particles. So we design a little bit of physics, sorry. We think that our hypothesis is that when you have a drying droplet like this, an important parameter is the ratio between the diffusion time of the solutes within the droplets over the drying time of the droplet. This is called the Peclet number, PE, okay? And if you want to put numbers and to compute something, this diffusion time over the drying time can be computed as the velocity of the drying front, how fast the droplet evaporates, multiplied by the radius of the droplet, and divided by the diffusion coefficient of the solute or a colloid that you put in your droplet. Okay? So this Peclet number can be, you have two extreme conditions. One of them is the Peclet number is smaller than 1. It means that you are drying the droplet very, very, very slowly. So the solute has the time to diffuse to the center of the droplet as you dry it, and you end up with dense particles. If you're on the other side, if your Peclet number is larger than 1, it means that you're drying much faster than the solute has the time to diffuse back in the center. So you have, during the drying, formation of a shell, and you end up with porous particles. Then the porous particle can have different morphology depending on the mechanical properties of the solute crust. So these are examples. So these are drying droplets I'm going to show you. This is not 5 millimeters, but 5 microns. So in some cases, when you use colloids, you can have these wrinkled droplets and particles. And this is an example from other people, Reinhard Wering from Canada, that showed that with a single, I think it was a sugar, when you modulate the Peclet number of this sugar in the spray dryer by changing the speed of evaporation, you could go from spherical particle to donut-like particles. Okay? So, to verify this Peclet hypothesis, because verify it after us, we started with lactose in what we were using at the time, a mixture of ethanol and water. And when you spread dry lactose with a mixture of ethanol and water, you get small particles that have approximately 4 micron geometric diameter and a 3 micron aerodynamic diameter. If you want to modify the Peclet number, we add in polystyrene nanoparticles to the suspension. These are 170 nanometers polystyrene nanoparticles. They're not used for drug delivery, but just for the sake of understanding the process. And when you just add these polystyrene particles in the same solvent, you end up with large particles that are actually made of nanoparticles. So there is a crust of nanoparticles, and it's really hollow. And if you measure the diameter of these particles, you are about 20 microns, whereas the aerodynamic diameter is only 10 microns. So if you enter numbers, you have in the spray dryer a droplet that is about 50 microns in diameter, in a radius, a drying time that is on the order of 1 second. And indeed, for lactose, if you use the diffusion coefficient of lactose, you have a Peclet number around 10, whereas for latex nanoparticles, you have a Peclet number around 2000. So by changing the Peclet number, you can change the morphology of the particles. Actually, we also did other experiment where we got rid of lactose, and we compared the spray drying of only the colloids in water and in ethanol water. So in water, we end up with these donut-shaped particles that are made of nanoparticles that you can really see very well. They are characteristic of like a football that you just uninflate, and it's really buckled. And if you spray dry in ethanol water, you have a coexistence of this buckled shell with hollow particles that are really made of 3 layers of nanoparticles. Okay? So we wanted to really check what was happening. So what we think is the mechanism, we have a suspension. When you dry, the nanoparticles are trapped at the liquid interface because we are drying very fast compared to the diffusion. We form a shell, and in some point you have some buckling in water, and for ethanol water you have, we think, an explosion, because we saw a lot of exploded particles like this. So in order to visualize this phenomenon, we use what we call Leidenfrost drops, and we did direct visualization using a fast camera, and we have size control of the size of the droplet. So Leidenfrost drop is when you have a hot pan on your stove, and if you heat at sufficient temperature, then there is a vapor film between the droplet of water that you put on the surface and the surface. And this vapor film makes the droplet levitate on the surface. You can do it in your kitchen. I think there are many videos now. Because of perfluorocarbons are not good for health, now people are trying to sell stainless steel pans, and they tell you if you want to be at good temperature, you should do the water droplet test, so it has to levitate in order to be able to use it and not to stick. So in this case, we have non-weighting droplets, no contact with surface. They are spherical if they are small enough, and we can control the temperature using the hot plate. So we made a lot of movies. We had a lot of fun. I'm going to show you some of the movies, if it's working. Yes, here. So this is a droplet of polystyrene. We are on the surface, and we look at it drying. And you can see it's spherical at the beginning, and at some point, it's not spherical anymore. And you will see the buckling process happening here. Okay? So we made a lot of movies. This is another image of a buckling. And we computed the numbers. We have the mixing time of which is the diffusion time on the order of 10 to the 1000 seconds, 10 to the 3 seconds. The drying time is of the order of 60 seconds, and we have a Becquerel number that is much higher than 1. And what we saw, and it's a little bit of physics, is that the buckling diameter, the diameter at which we start to deviate from the sphericity of a droplet, scales with the volume fraction of a particle. So basically, if you put a lot of particles, you would have a large buckling radius, so it would start to form a crust earlier. If you have a lower concentration, it will form a crust later. And it also scales with the initial radius of a droplet. So this was shown for 170 nanometers nanoparticles. We did the same thing for 2-micron colloids because it's a large droplet. So you can see, again, the movie. I think it's exactly the same, these particles. And you will see the buckling. And you really have the same shapes that we see with spread drying, which was very interesting. Okay, here is the buckling. Okay. So the buckling comes from, it's a bit complicated to explain, but the buckling comes from the difference of pressure between inside and outside. And normally for the critical pressure for a shell, it depends on the Young modulus, so the mechanical properties of the shell, and the thickness of the shell over the radius of the shell to the square. So we did some simulation with colleagues to simulate what was happening, and using this modulus, it was easy to see that you can get exactly the same shape with simulation and the experiments. So I'm going to maybe skip this because it's a bit complicated. But basically, what we would say is the buckling, the fact that we see this buckling is also depending on the viscosity of the solvent and the permeability of the shell that we form on the surface. And this is important for when we sorry, I'm going to skip this as well. Sorry. This is important for ethanol water mixture. With ethanol water mixture, we know that the mixture of ethanol and water changes the viscosity of the solvent, and actually we measure the buckling diameter as a function of a mixture of ethanol and water, and what we see is that the buckling is changing with the volume fraction, and this changing also is more or less related to the viscosity. Because we have indeed an increase of viscosity and then an increase, we see an increase of the buckling radius and then an increase, basically. And the last movie for ethanol water, we see the buckling, but we also see the explosion. So really, what was really nice with these experiments is that we have a spread dryer, we can vary the parameter, but we cannot look what's happening in the spread dryer. We just can look afterwards. But with this simple Leidenfrost experiment, we can really examine what will happen in the spread dryer, and maybe we can screen formulation with this Leidenfrost experiment very easily in the future. What is interesting is that when I did this a long time ago, I proposed the industrial to use this system for looking at the buckling and understanding the spreader, and they were not interested in the pharmaceutical technology. But 10 years after, there was a company was doing like ceramics, that they are using exactly the same process of spread drying, and they implemented the Leidenfrost experiment in their manufacture in order to understand what was happening and to screen some of the formulation. Okay, so if we go beyond, so as Hervé said, now we can use the fact that we have microparticles with nanoparticles inside for therapeutic application. This is really what we call the Trojan particles that I told you about 2 days ago. So this is a way to have nanoparticles in the shelf-stable form, in a dry form, that can be delivered by oral injection or aerosol route, and we can have controlled release of nanoparticles directly when we want in the lungs. I think, yeah, maybe it's not correct. Okay, no problem. So Now we have different systems that I'm going to expose to you. So this is exactly the same image that Hervé presented. We have the bronchial regions where we have the mucus gel, and then we have the alveolar region when we have the lung surfactant and the alveolar macrophages. And we have these three types of particles that we can use. The porous particles that we can obtain by spray drying. The Trojan particles where we have a mixture of nanoparticles and porous particles. And we can also deliver directly the nanoparticles by nebulization. And depending on where we are in the respiratory tract, we have mucus or not mucus, we can we are going to be interested in the ratio between dissolution of the particle over the and disintegration over the absorption of the drug. And in some cases, it's interesting to have macrophage targeting in the case of inflammation or infection, because macrophages are key cells for this type of pathology. So we can use this type of particles for local and systemic effect, as Hervé presented. So I'm going to show you mostly things with porous particles and Trojan particles. I will show you examples of the effect of the API physical-chemical properties on pharmacokinetics and lung distribution, and also on what's happening during the spray drying process. And I give you example of APIs. We will talk about DTPA, which is a chelating agent. I will show you example of sodium alendronate. These two are very hydrophilic. We will have pyrazinamide, which is a drug that is used for sterilization of the lungs for treatment of tuberculosis. It's also very hydrophilic. Tisaconitate, it's a new antiviral drug that has very promising effect for treating influenza. These are hydrophilic. And then I will show you the example of a hydrophobic API, dexamethasone palmitate, that we formulate into a dry powder. I will present several examples of Trojan particles. And really what we saw during this process as we evaluated the pharmacokinetics of the drug is that there is a strong effect on the physical-chemical properties of the API on the ability of the API to cross the epithelial barrier and go to the systemic circulation or not. Okay, so the first example is DTPA. In France, we have a lot of nuclear power plants to produce electricity. And for producing the electricity, we use combustible that is made of plutonium, americium, and uranium. And usually they are also combustible is made in like little bricks that has to be broken. And in some cases there is some contamination because the breaking creates like dust that you can inhale if you're not well equipped. You can have also so you can have contamination of radioactive compounds by inhalation, by ingestion if you're not manipulating correctly and you leak your hands afterwards. And you can have also warm yourself and have penetration of these radioactive compounds on your skin. So after the contamination, you have absorption, distribution, and transferring, which is a plasma protein, plays an important role in transferring this radionuclide to the different organs of accumulation, which are the liver and bones. So depending on the radioactive compound, plutonium, americium, neptunium, or uranium, you will have different accumulation. So for example, plutonium goes 30% in the liver and 50% accumulate in the bones. Americium is the reverse, and neptunium is totally different. And the accumulation of this radionuclide in this tissue leads to chemical and or radiological toxicity. Okay, but mostly what I learned at that time is that what is dangerous is not the radiology of the radiological toxicity, but mostly the chemical toxicity. These are metals that are very toxic. So there are treatments to prevent the accumulation of this radionuclide, and one of them is DTPA. diethylentrylamine pentacetic acid. It's indicated to treat contamination by plutonium and other radionuclide, and it's used either as an intravenous injection of salts of DTPA, either calcium or zinc, and also by inhalation of a powder. Okay, and the usual dose is on the order of 1 gram of DTPA by oral route, and by injection, sorry, and 200 milligrams by inhalation. However, this drug is a very annoying drug because it has a low biological half-life, which is lower than 20 minutes in rats. It has a high urinary excretion rate, and it has a low tissue distribution because it's hydrophilic and very iodized. So often the treatments are very long, over weeks and months, and they require multiple administration and lead to variable efficacy that is on the order of 50%. And in particular, the dry powder that was available at that time when we started to work was very badly characterized. It was a micronized powder of DTPA, not depositing efficiently in the lungs, and we wanted to reformulate this powder. Because DTPA is forming a 1,1 complex with plutonium, and in all the cases of contamination in France between this time scale, there is approximately 500 contamination, which is not a lot, but it's still a number. Half of them was inhalation as a route of contamination. So micronized DTPA exists, but is not working well, so we wanted to optimize the powder. So the idea is to concentrate DTPA where plutonium deposits the other region, and taking advantage of spread drying of the powder. So inhalation is an easy and quick route of administration. You don't need healthcare workers, so the worker in the nuclear plant can have the inhaler in their pocket and self-administer if they think they have been contaminated, and then that will be taken care of by medical workers. And it's also adequate for mass treatment in case of terrorist attacks. The idea is, can we systemically distribute DTPA? So our vehicle is these large porous particles that can be obtained by spread drying. They're easy to disperse. They can have efficient lung deposition up to 60% dose. And you can use the aerolyzer of Novartis, that is this one, to deliver it properly. So basically the powder will be in this capsule. The capsule is punctured with little needles, and then it's breath activated, so the capsule rotates and the powder gets out of the capsule. So I'm going to show you a classical way we formulate these drugs. So we started during the postdoc of Claudia Jarvelas with calcium DTPA, and we just spread dry the drug by itself in water because it was, or in a mixture of ethanol and water because it's very soluble in water. So we end up with particles of 2 microns, very sticky powder. Really, it was sticking even to the, when you recover the powder, it was sticking to the cyclone. Not good. So we added a lot of excipients to make the powder better for inhalation. So we have still 75% by weight of DTPA. We added DPPC, which is a lipid that is the main component of the lung surfactant at the surface of the alveolar region, and it's also an absorption promoter. And we added a little bit of leucine because leucine is an excipient that allows the particles to be dispersed easily. So 75% DTPA, 10% DPPC, and 50% leucine, 2 grams per liter solid. And in order to promote some porosity, we also added ammonium bicarbonate, which is like levadura. So it's making a baking powder effect, and it's making the particles porous. Okay. So we go from this type of morphology to this type of morphology, a little bit larger particles. So we, in this case, after we prepare the powder, we characterize by laser diffraction, and we compared our formulation in red with the DTPA formulation that is micronized. So you can see the DTPA formulation leads to smaller particles, compared to our particles that are on the order of 4 microns. And also there are a lot of aggregates for the micronized DTPA, where in our case it's rather monodisperse. And if we measure the density of the particles by tap density, as is done for powder, you can see that you can decrease the density by a factor of 10 between the micronized powder and the spray dry powder, which is very good sign for deposition. Then what we did is to evaluate the aerodynamic properties of a powder using a multi-stage liquid impinger. So this is this type of device where you put the inhaler on the top. This is mimicking the mouth of throat, and then with a pump, you simulate an inhalation, and with an air flow rate of 60 liters per minute for 4 seconds. Then the powder deposits on the different stages of the impactor, and you can calculate from this by using an analytical method that is good. The fine particle fraction, which is the amount of particles below 5 micrometers, sorry. And you can even distinguish between the bronchial and the alveoli, which can give you the alveolar fraction. So when we have this type of formulation, what we first do is to evaluate the emitted fraction from the inhaler. And in the case of a micronized DTPA, we have 90% emitted, whereas it's 100% from the optimized powder. We can, however, put more powder in the micronized DTPA than with the optimized powder because of the change of density. Okay, but when we compute the fine particle fraction, we have a huge difference between 17% particle fraction for the micronized powder with 50% in the case of the optimization, and also in the case of the alveolar fraction with a much higher alveolar fraction. So this powder has a better lung deposition than the formulation on the market. Then with our collaborators at Center of Atomic Energy in France, we evaluate the efficacy of the aerosol versus the IV administration. So in the first contamination was contamination with a soluble form of plutonium, which is plutonium nitrate. And in this case, we compare the control and IV of DTPA versus the aerosol by measuring the amount of radioactivity in the lungs, liver, and bones. When we treat the animal, we see that there is a reduction of the lung radioactivity with the IV that is much lower than with the aerosol. Indeed, we are delivering the aerosol directly to the lungs, so we can decontaminate the patient, basically. But for the liver and the bones, the decontamination is similar. So this, and we also see an increase of urinary expression using the aerosol because we have better decontamination of the lungs. This is interesting, it's working well, but this is not a real contamination because the real contamination comes with the oxide form of plutonium. And we did again the same experiment, and we compare IV and aerosol. And what we saw is that in the case of liver and bones, the aerosol was equivalent to IV, but in the lungs there was no effect, neither of aerosol or IV in terms of radioactivity. So as a conclusion for this part, we can see that the treatment should be administered as soon as possible. That's why it's good to have an aerosol, because you can do it by yourself. And the aerosol represents really an easier emergency treatment. But if you look at the lung slices, in fact there is a little bit difference between the aerosol and IV. In the case of the control rat with IV or no treatment, you see that when you do autoradiography of the lung slices, you don't have exactly the same thing. Here, the control rat, this is basically the particle of plutonium, and then the soluble form is the little dots. But when you treat them with DTPA powder, you see still the big particles, but the little dots have disappeared because we probably are able to carry the soluble part of the uranium plutonium that has deposited in the lungs. So it's good for the patient because we can quickly decontaminate. Sorry. And if we repeat the treatment, we can, by 1 time or 2 times, you can decrease the amount of this isolated form in the lungs. So it's really good to imagine this type of treatment for patients that are contaminated by plutonium. And we wanted to have to go further to a commercialization of this formulation. But unfortunately, it was at the time of the big influenza emergency in France, and the central pharmacy of Miami was occupied to prepare the vaccine against influenza. They didn't have the time to go for this formulation, and they also considered, okay, it's not a big issue because we only have 500 contamination in 30 years, so maybe we should stick to a formulation by IV. It's okay. Okay, so this is one example of what we can do. This is very detailed, and I can show you now a more example of different formulation of different drugs. So when Laetitia Cruz came to our lab, she was interested in formulating sodium alendronate as a dry powder. This is a very hydrophilic uncharged substance that is complexing the metals and precipitates very quickly. It's used as a post-menopause osteoporosis treatment, and it has a very low bioavailability because of its bad absorption, and also it has side effects. So the idea of Laetitia was to formulate a powder of sodium alendronate in order to deliver it directly to the lungs and bypass the oral tract and try to increase the bioavailability. So we spray dry again sodium alendronate. In this case, we only needed leucine and ammonium bicarbonate in order to get a powder of about 5.5 micron in geometric diameter, and again the same type of density. And we evaluated that 60% of the powder was depositing in the lungs and 40% in the other region, with no acute toxicity in the animals. It was then administered to dogs at 2 milligram sodium alendronate per kilogram by either IV or intratracheal administration to the animal. And we saw that the bioavailability was increased compared to the oral route using the aerosol, which was very promising. Still, it's a very low bioavailability, so it's not the best one. We then, with another PhD student, Duifam, we tried to optimize the formulation of pyrazinamide, which is a hydrophilic API used for the treatment of tuberculosis, to shorten it from 9 to 12 months to the current 6 months. So pyrazinamide is this very small molecule. It's it was spray dry with excipients, because if you just spray dry PZA without excipients, it crystallizes into large crystals that are not good for deposition in the lungs. So in this case, we needed a lot of excipients because of its tendency to crystallization, and not only DPPC and leucine, but also hyaluronic acid to prevent the crystallization of using this polymer. So again, we get nice particles, a good density, and good deposition in the lungs. So with Dri, we went to the pharmacokinetics evaluation of pyrazinamide by administering the powder by insufflation directly in the rat. And what was surprising for us by comparing with IV administration is that in this case, if you look at the concentration in plasma by IV or intratracheal administration, you have approximately the same concentration. And again, in the epithelial lining fluid, when you do a brocal lavage to measure the concentration in the lining fluid, you have also approximately the same thing. So what we think is that we were not able to see any concentration of PZA in the other macrophages, which is the target of tuberculosis. So what we think in this case, because the molecule is very small and very permeable, it dissolves very fast, and there is a quick blood passage either from one side or the other. and it doesn't go to the macrophages. So this is not a good way to target the macrophages. So you see that in the case of hydrophilic compounds, there is passage from the lungs to the bloodstream, because in the case of DTPA, we can prevent the accumulation in the liver and bones. In the case of sodium alendronate, we can increase the bioavailability. But in case of pyrosinamide, there is no real interest in giving the drug by inhalation, because it's going from IV from the blood to the lungs and from the lungs to the blood. So it really depends on the properties of the drug itself. So let's go to a last example of pure drug, which is dexamethasone palmitate. It's a hydrophobic drug, so it's a lipidic prodrug of dexamethasone, where we link a palmitate chain to dexamethasone. And because we link this chain, it's very insoluble, and we think that we can have a long-acting form of dexamethasone directly in the lungs to treat asthma or COPD. So we spray dry with adequate excipients, again the same usual suspect, DPPC, hyaluronic acid, and ammonium bicarbonate, and we get large porous particles that are much larger, very low density, and good deposition. But in this case, it was difficult to have a huge loading of dexamethasone palmitate into the porous particle. We have only 5%, otherwise they aggregate a lot, because dexamethasone has also the tendency to crystallize. So Alain did the pharmacokinetic evaluation, and in this case we were able to measure dexamethasone palmitate in epithelial lining fluid in the plasma, but we also measure the concentration of the drug itself, dexamethasone, epithelial lining fluid, and plasma. So what we see with dexamethasone palmitate is that you see a huge concentration of drug in the epithelial lining fluid with a decrease over time, over 6 hours. But there is no passage of a drug in the plasma because it's very hydrophobic. On the other hand, with dexamethasone, there is a decrease of concentration that's coming from the degradation or dexamethasone palmitate separates into dexamethasone and palmitate. So there is a little decrease of and concentration that are 2 orders of magnitude lower. But there is a passage of dexamethasone in the plasma, but at a very low concentration, and with a 2-time kinetics. So we have low prodrug passage in the plasma, better dexamethasone passage in the blood, and we think that there is a large tissue distribution because of the hydrophobicity of the drug. So it goes into the tissue, but again, we have no drugs in the alveolar cells. So the drug is not going to the cells because we are not into nanoparticulate form. That's why it's important to have a Trojan particles, and I will show you later why. Last example with a drug that we started to work with about 4 years ago is cysaconitate that our colleagues from University of Tours in France, they show that there is an antiviral effect of succinate, which is a metabolite. This is a very clear antiviral effect on contaminated cells. And they thought that because succinate is a metabolite of the Krebs cycles, maybe other metabolites of the Krebs cycles have an effect on anti-influenza. So they screened a bunch of metabolites for the Krebs cycles, and they realized that cysaconitate, which is this molecule, has a very good efficiency. So it impairs viral polymerase activity across a range of different influenza subtypes. It also has, in addition to antiviral effects, anti-inflammatory effects, and they prevent the inflammation, which is very beneficial for the treatment of influenza, because not only the virus is contaminating, but there is also a large immune response, which if you decrease a little bit, is good for the patient. So they recently published these results where they administer cysaconitate versus oseltamivir in contaminated animals at day 2. and they see that with control of azacitidine, you have all the animals are dead after 10 days, whereas with cisaconitate, there is a very good survival of the animals. I think because you decrease the inflammatory effect of the virus, you can protect the animals better, in addition to the antiviral effect of cisaconitate. So the idea with this collaboration was to try to formulate a powder of cisaconitate to treat influenza. And this is a good example of serendipity. So we started with cisaconitic acid. And what we realized that even though we used hyaluronic acid, leucine, we were not able to formulate this drug as a dry powder. We tried in ethanol water, in water, no possibility. And for some reason, I don't remember why, we decided that we could neutralize a little bit the cisaconitic acid in order to make it more neutral using sodium hydroxide. So we have cisaconitate and not cisaconitic acid. And we realized that we were able to make nice powders. And what was interesting, my student made a mistake in the calculation. And not only neutralized, he thought he neutralized the free function of cisaconitate, but in fact it neutralized only 1/3 of the fraction. So he realized that you can modulate the neutralization and you can add different yields of production, different sizes of particles, and different size polydispersity. So we then evaluated the deposition of particles that we produced, and we saw that there is no difference of emitted fraction. There is kind of a difference of the fine particle fraction depending on the degree of neutralization, and also there is a difference in the alveolar fraction. So basically, when you neutralize only 1 out of 3, it's better. And what was also surprising is then we evaluated the effect of the powder on contaminated cells. So this is the neuraminidase activity, which is a biomarker for virus activity. You see that with cisaconitic acid from sigma, you have good neutralization of the antiviral activity, but you lose a little bit this neutralization of the activity when you use the powder, mostly because you modify the number of carboxylate moieties that were charged or not. And it was the case not only for cisaconitate, but for other metabolites that possess these carboxylic moieties. So we have a progressive loss of antiviral activity for the neutralized powder, and we also have a progressive loss of anti-inflammatory activities, and we still don't understand why, because the cells are in PBS, so all the molecules should be charged the same way. And we are trying to do pharmacokinetics in mice of this drug, but it's complicated to dose because we have also a lot of cisaconitic acid that is endogenous, so we have to find a way to do it properly. Okay, do you have questions so far? No? Yes?
Yes, I have a question about the application with for the decontamination of people exposed to plutonium, I think it was.
Mm-hmm.
Okay, so you established that the treatment should be assessed ASAP, right?
Mm-hmm.
So how long would you recommend to, for example, if I waited for 20 minutes to apply the treatment?
20 minutes I think is good.
Okay.
We did, I didn't show, but we did an experiment where we did a contamination.
So you have the profile of that?
I think they have a profile, yes. We did 2 hours after contamination exposure, it was working well.
Right.
But 24 hours after, it was not working properly.
Okay, so within the first 24 hours, you think it's
Yeah, I think
it's good to have a treatment? Okay.
Okay, I will continue. So now I'm going to show you an example of Trojan particles. So as I explained 2 days ago, it's a way to deliver nanoparticles by inhalation more efficiently, because otherwise they will not deposit into the lungs. And the main idea we want to, by using nanoparticles, Trojan particles, is to improve the macrophage target. Because we saw that we were not able to deliver either dexamethasone palmitate or pyrazinamide to the other macrophages. So, but this lady, as I showed you, she was able to deliver to the macrophages using these Trojan particles. But we think that she was using PLGA nanoparticles to encapsulate rifampicin, but we think that polymers are probably not the best material we want to deliver to the lungs, especially PLGA, because it's when it's degrading, it releases acidic moieties, and it's okay in your bloodstream because you have a lot of flow, but in the lungs it will stay forever. So maybe we'll release some kind of acidification with time, so it's not good for the lungs. So we switched to other nanoparticle type, and during the PhD of Ludmila Pinheiro, who came from Brazil in our lab, we worked with nanoparticles of budesonide for COPD treatment. So basically, we did the same thing to budesonide that we did for dexamethasone. We link a palmitate chain on budesonide, so we yield budesonide palmitate. And using a process that we patented a few years before, you can formulate these prodrugs of corticosteroids as nanoparticles using a simple excipient, which is DSP-PEG, which is used in the vaccine for COVID-19 that we've seen before. So you solubilize your prodrug and PEG into a chloroform or dichloromethane. You vortex well. Sorry, there are some things missing, I think. You inject the organic solution into water, you vortex to make an emulsion, you then sonicate and evaporate, and you get 150 nanometers particles that are stable over 50 days. They have a very high budesonide palmitate loading, which gives a very high budesonide loading. Okay, so we have these very nice nanoparticles. In addition, we can modify their surface by using DSP PEG mannose. So as Hervé showed, that mannose is interesting for targeting macrophages. And indeed, we show that you can vary the proportion of mannose on the surface and then verify by, when you add concanavalin, you can verify that particles are interacting with concanavalin and forming aggregates. And the mannose is present on the surface. We can have macrophage targeting when you just incubate the nanoparticles in cell culture. So you see that the pegylated nanoprodrugs, they interact with the macrophages, but the mannosidated ones, they interact even better. And this is shown as a function of time. So you see that in red, the mannosidated, they interact better with the macrophages, they're internalized better. It's ATP dependent, it's endocytosis. And when you have competition with Manan in 3, you can block the internalization. Okay? And when you look at the anti-inflammatory effect of these nanoparticles, you have indeed a good efficacy with concentration. And there is a little improvement of efficacy when you use mannosidated versus pegylated only, because of the better targeting of macrophages. So we were wondering, are we able to load these nanoparticles into dry powders for inhalation? So that's what we did. We spread dry these particles with only leucine, and they yield Trojan particles. You see that when you have only leucine, you have very different morphologies, like, I don't know if you call sand roses. I don't know if you ever have this in the Atacama Desert, maybe. Like this, and you cannot see the nanoparticles. But what we can see is that there is a little effect on the loading of nanoparticles over the characteristic of the powders, but mostly for the impaction, there is a big difference when you increase the nanoparticle loading, you decrease the deposition in the lungs a little bit. So we work with a 5% loading. We then evaluated the pharmacokinetics, and in this case, we look at drug and prodrug concentration in plasma, epithelial lining fluid, alveolar pellet, and lung tissue. So these results were a little bit controversial because we are not sure of the analytical efficacy of our methods, but so we have low passage of prodrug or the drug in the plasma, as we saw with the method palmitate. In the epithelial lining fluid, of course, we have a high concentration of drug and prodrug, but what was interesting in this case, we were able to get the drug in the alveolar macrophages at a very high concentration. And we can see also there is something in the lung tissue as well. So we are not 100% sure on the exact concentration because we think the analytical should be checked, but at least quantitatively, but qualitatively, we have good macrophage targeting. So really, using this Trojan particle is good to target the macrophages in the lungs. And you can do it. Well, I wanted to show you that this technique is very interesting because you can use also lipid nanoparticles for gene therapy. So in this case, they use siRNA that silence GFP in the lungs by using trialos and these lipid particles that contain siRNA. The spread drying process is soft enough not to destroy the siRNA, and you keep a good silencing effect even after spread drying, which is really a good thing. This is work from Olivia Merkel in Munich in Germany. So the last example, I think, no, many more. So what we did for corticosteroid, we can also do it for anti-tubercular drugs. So Van Nguyen, which finished 2 years ago, she tried to develop not pyrazinoate prodrug with lipids, but with polymers. So we use malic acid, which is our favorite polymer now, which is a natural polymer that can form very small polymers by condensation. We can graft an ester bound to the pyrazinoic acid and form a pyrazinoic ester that we can then graft to the polymer. And in this case of these prodrugs, we play with the linker length, C6, C8, or C10, in order to modulate the ability to release pyrazinoic acid. So we then formulated the prodrugs into particles. They are about 150 nanometers. They have good colloidal stability and good, very nice space. And then we assess the release properties of these prodrug nanoparticles. And we can see that we can modulate the release as a function of the linker length, but also as a proportion of the linker that you put on the polymer. So if you put too much pyrazinamide, it's very difficult to release the drug, and it goes very slow. But if you put only 50% of the carboxylic acid of malic acid are conjugated, you can have a modulation of a release. So the nanoparticles, what we think is happening is during the first day, the particles are kind of swelling, and then there is some kind of hydrolysis and disassembly that continues over time and releases the drug. So the drug release is regulated by the system hydrophilicity, and it's higher for nanoconjugates that are only 25% loaded, and we have a complete drug release in 8 days. So it's rather slow, so we were not sure it was enough for treating tuberculosis. So we checked on the infected macrophages, and what we see is that unfortunately these conjugates, they have some kind of toxicity. So if you want to have an effect, you have to incubate with a low concentration of conjugate, otherwise you get some toxicity. But if you incubate with this low concentration, then you can kind of inhibit Mycobacterium tuberculosis in infected macrophages after 6 days, which is good. But the let's say the toxicity of the nanoconjugate is not good enough to go to animals for this type of experiment. Still, we can formulate the nanoconjugate into Trojan particles very efficiently with good fine particle fraction on the order of 80% of deposition and good alveolar fraction, but there is some kind of aggregation after redispersion in water, and the toxicity is really preventing us to go further in the evaluation. Just to finish, I will show you that also one thing that we should do is try to understand how the particles, Trojan particles, what's happening to them after deposition in the mucus layer. Do we have a fast disintegration? How do the particles disperse? Because in the other region, maybe it's fast, but in the mucus, we have to disintegrate faster than in the mucus clearance. So with these guys, we did a very preliminary experiment where we used 3 alloys and we put different amount of nanoparticle of polystyrene to do Trojan particles, and then we evaluated what was the minimum concentration of matrix we need in order to get good dispersion of the particles in a static condition. So if you just use a lot of particles, you are not able to disintegrate them, so you want to reduce, to put more matrix in order to separate the particles from each other in order for them to decrease. And what we saw when we did mucus deposition with artificial mucus, using the insufflator to deposit the powder, is that if you don't have any stirring of the mucus, the particles stay intact and they don't disintegrate, even though we are able to redisperse them in water. So we think that there is the need, the mucociliary clearance is important for disintegrating the Trojan particles. And with our colleague from Paris Cité Université, we are trying to design a microchip in order to mimic the mucociliary clearance. So we create magnetic pillars on which we can put a mucus layer, and we can make the magnetic pillar move like that in order to see if we are able to disintegrate the Trojan particles and release the nanoparticles just by the mucociliary clearance motion. So this is work in progress, and the problem here is not the chip is done. Now we have to find a good mucus model that is transparent. With this, and I'm on time, I'm going to conclude. So hydrophilic and hygrophilic drugs, they have a different distribution after inhalation depending on the physicochemical properties, and there are people who are trying to assess the biopharmaceutical classification of drugs in the lungs as compared to what is done for the oral route, and I think it's a little bit different. And sometimes the formulation can be tricky by spraying. So when I was young, I thought that if you have a drug, you can spray dry in 6 months, you have a powder, it's okay, but in fact it can be more complicated. If you want to target the macrophages to have a local effect on inflammation or infection, I think we should use Trojan particles, which give to better macrophage targeting. But we still need to understand how these systems do in vivo or in vitro to understand better how they are working. So with this, I'd like to thank all the people who contributed to this work, and you. And if you have questions in Spanish or English, puedo contestar.
¿Preguntas?
Sí.
I have a question. It was one of your last slides about the mucus chip that recreates the mucus movement. Was that done only for mucus in the lung, or can it be extrapolated to?
I think there are some chips that are for stomach, but we are thinking more of the lungs, because in stomach you have the mucus layer, but you have also a lot of fluid So it's a little bit different. In our case, we have just the mucus layer and then the air. So it's at the same time complicated and simple. So, but already it's very complicated. It took to make the chip. It took about four years because sometimes if the pillars are too close to each other, they stick to each other. You need also to because you see the motion, but it's not only you don't put the magnet like that. In fact, it's a round system, and the magnet goes like that below. And as time is passed, it's doing this. So it's more complicated than what you think. And really the main problem now is the mucus layer, because if you use mucus from pig stomach, it's very, very non-transparent, so it's not good for us. And also it contains a lot of bacteria. So when you dissolve it, it's okay. But after 2 days, you have bacteria everywhere. So you have to sterilize it. It's complicated. And we are working with other models. And there, in the literature, you can see several recipes for mucus. And I don't know, it's complicated. At the beginning, we thought that it would be very easy, but mucus is complicated.
And so that's the team that developed this.
Yes.
And they are also the ones who work with, or have a similar one for stomach.
I don't think they have for stomach, but I can try to help you find for stomach. Yeah, I see why you're interested for the extra exosome.
Nicolás. No, sí. Podemos pensar en un futuro, probablemente, en sistemas multidrogas.
Sí, claro.
Sí.
Por ejemplo, utilizando las micropartículas troyanas, se puede pensar que una droga está con los excipientes y se disuelve muy rápidamente, y la otra está adentro de las nanopartículas protegidas de la degradación. Sí, es interesante. Pero me parece que cuando uno habla de sistemas multidrogas con la industria, dicen que es un poco más complicado, mejor tener dos medicamentos separados porque las dosis no son exactamente las mismas. Tenemos que pensar en las dosis, por ejemplo.
Sí, es complejo, me imagino, el sistema de liberación.
Pero pienso para asma es interesante porque necesitas los corticosteroides y los grupos hidratadores al mismo tiempo, pero puedes elegir la dosis de cada uno.
En tuberculosis también.
¿Qué?
En tuberculosis
Sí,
también.
también.
Y lo otro, ¿qué tecnología, técnica utilizan para cuantificar el plasma?
Depende de la droga. A veces es suficiente la HPLC y a veces necesitamos el CNS. Dependiendo de la dosis también. Si hay una dosis importante, puedes cuantificar con HPLC, y a veces la dosis está muy baja. Por ejemplo, para tisaconitat no da mucha señal con HPLC, entonces necesitamos método del CNS.
Sí. En realidad, consultar sobre la experiencia tuya y de tu grupo cuando quieren diseñar una determinada morfología. Pensando que no todos somos físicos, ¿qué crees tú que es conveniente hacer diseños de experimento para... porque siempre me preguntan a mí, ¿por qué no hacen un diseño experimental? Y yo digo, no, porque al modificar un parámetro cambia absolutamente todo. Me gustaría saber tu opinión.
Tengo la misma opinión.
¿Sí?
Porque pero hay mucha gente que con el SPLRN hacen diseño de experimento, pero yo no sé suficiente de diseño de experimento para hacerlo. Pero pienso que puedes hacer el diseño de experimento sin modificar la formulación, pero modificando la temperatura
parámetros del equipo.
Del equipo, sí, eso sí, pero con la formulación ¿Sabes que cuando pones 5% de este y este es totalmente diferente?
Totalmente.
Pienso que podemos utilizar los experimentos de Leidenfrost para ver el efecto de la formulación y diseño de experimento para las condiciones de secamiento, por ejemplo.
Boquilla de 3 fluidos no tienen cosas más probadas.
No tenemos, pero sería interesante.
Sí, es que acá la hemos usado. Sí.
Otra pregunta, inglés, francés,
Español.
español.
Con respecto a la primera pregunta que te hacían, bueno, es súper distinto el tema del flujo de los fluidos en el estómago, acá en el pulmón, en este espacio. ¿Es conveniente o vale la pena hacer un sistema de microfluídica para este microchip, para simular cierto movimiento? Y relacionado con lo mismo, ¿estos micropillars son flexibles o son fijos, van up and down solamente?
No, son flexibles.
Son flexibles.
Son flexibles.
Vale, y eso lo controlan con la...
Lo controlas con la cantidad de nanopartículas magnéticas que pones adentro y también con el PDMS que utiliza, que puede ser crossing.
Sí, crossing.
Entre
cruzado, entre cruzamiento.
Más o menos,
Vale.
para hacer, pero tiene experiencia en esta universidad.
Bueno, porque la siguiente pregunta era esa, ¿cómo lo fabrican? Con un masking, con el PDMS.
Una máscara, sí.
Vale. No es que usen fotolitografía ni nada de eso.
Sí, utilizan fotolitografía para hacer la máscara.
Vale.
Y después poner las nanopartículas magnéticas y el PDMS y después lo pelan. Pero es más complicado que pienso.
Vale.
Pero está complicado la fabricación.
¿Alguna otra consulta?
Tienen hambre.
Otra cosa. Para retardar la liberación de un fármaco, imaginen, independiente de la naturaleza, ¿ya? Es preferible utilizar excipientes, supongamos, lipófilos,
Sí.
en el caso del spray dryer, o buscar el entrecruzamiento que vimos ayer en exposiciones, por ejemplo, buscar polímeros catiónicos y aniónicos, porque a nosotros no nos resulta porque nos precipita antes de atomizar. Pero a lo mejor ustedes han encontrado otra manera de tener una matriz entrecruzada y que sea eso lo que retarde la salida del fármaco.
Lo que puedes hacer es utilizar el sistema con 2 puntos de llegada al...
Sí, lo hemos hecho.
Bien, vamos a hacer eso y...
Nos precipita
Sí, depende de...
en la boquilla.
O hacer reticulación después con las partículas secas.
¿Lo han hecho?
Lo hicimos con Francine Boll, voy a presentar mañana. Sí, hemos preparado micropartículas de quitosano que no estaban reticuladas, pero después hemos hecho la reticulación después en glutaragilis.
No quiero ver. Bien. ¿No? ¿No hay más consultas? Bien. Agradecemos entonces a los estudiantes de esta mañana. Con respecto a mañana jueves, en la mañana tenemos una clase de 2 horas, de 10 a 12, acá. Y en la tarde partimos a las 2:30 en la Facultad de Farmacia. Y el viernes es diferente porque es la dirección de posgrado, en el auditorio de posgrado, pero eso es el viernes. ¿Ya? Bien. Hoy día quedan libres desde este momento entonces. Hasta mañana. Gracias.